I was like, if I travel to the Dakota.
Thanks, Stephanie. Appreciate that. I'm now unmuted. How about now? Can you hear now? Now that everything's unmuted? Yay. Good. Okay. Good job. Okay, we're going to get started today. You have me today. Last week you had Corby. You have me. This will be the last day that I will be teaching like in this environment. I'm still going to be assisting Corby, and on her coattails, we'll still be reviewing tests and clarification documents and things like this. They're shifting me a little bit because all of your final pass-offs for skills, they want to use the new and improved recording system, so we won't be using the camera anymore. And so in order to do that, I have to shift my energies there. So you'll see me, but not see me. So we're going to have a good day. And I'm so sorry you're not in class. We have healthy treats that we're going to be throwing around. Right now, though, let's start with our presentation on ginger, which is Maddie, Megan, and Jaden. Who's anybody in here that's got it? Okay. And we'll turn it over to that. All right, so okay. So we'll turn them over to the people that are presenting for ginger and go from there.
No, each one has one. Sometimes we have two. Like this test will have one on ginger and one on peppermint. Oh, I see. That makes sense. Fine. I guess we'll have.
Let me just test this here. Okay. Just tell me when you want it changed. Okay. All right. So speak nice and loud so the people online can hear.
All righty. Like they said, we're doing ginger.
And you can take off your mask if you want to be 6 feet away so we can hear.
All right. Okay, next slide.
Sorry.
You're good.
Can you guys hear me?
Yeah. Hello, man.
Perfect. So ginger is like a member of a plant family that includes cardamom and turmeric. It is a tropical plant that has green or purple flowers, and it has like a fragrant underground stem. That's called a rhizome. And ginger is commonly used for flavoring, for fragrance in food, beverages, soaps, and cosmetics. It was used as a flavoring agent long before records had even started. And it was an important item of trade that was exported from India to the Roman Empire over 2,000 years ago. And it was specifically valued for its medicinal properties. And then the Chinese and Indians have used dried ginger for thousands of years to treat just like stomach aches, diarrhea, and nausea. And today it's just mainly used in cooking, but it's also used for like the possible health benefits it can bring. Next slide. And then ginger is a herbal or a dietary supplement. It's just usually used to help support like good digestive health. Next slide. Okay, and then some complementary therapies that ginger brings. It can help relieve heartburn, and it also helps dissolve kidney stones. It's said to improve brain function. And then over here on the little image, there's some more benefits that ginger has. Some main ones is it can cure nausea. I think Jaden's going to talk more about that. But it can cure nausea. It can remove like excess gas in the body. It's said to prevent cancer, and it kind of helps with menstrual cramps or joint pains and stuff like that. So next slide.
All righty. Like we've already mentioned, ginger is used to help reduce nausea. A lot of times it's used during pregnancy. My wife's pregnant right now, and most of you knew that, but for those who didn't, she's been super nauseous, and our doctor was like, "Take some ginger." So there you go.
Is it working?
Real life experience. I think so. I don't know. She's taking all sorts of stuff to help that. But also it shows success in reducing nausea related to chemotherapy treatments. So the CDC reports that it's unclear if ginger is effective in reducing post-surgery nausea, motion sickness, rheumatoid, or osteoarthritis. I know with a lot of times, like with motion sickness, people, I don't know if it's lifestyle or it's unclear, but a lot of times people will take it before they like go on road trips or I don't know, like amusement parks just to deal with motion sickness. Or like if you're dealing with the flu, a lot of times they tell you to drink ginger ale to help settle your stomach. What was that? Class participation, go ahead. Forms of ginger are fresh or dried, tablets, capsules, liquid extracts, and teas. Interactions and adverse effects of ginger. So you can get heartburn. I don't know if any of you have ever drinking ginger beer. I love ginger beer, but a lot of the times it'll like burn your throat and kind of burn your chest a little bit for a while, especially if there's a lot of ginger in it. It can cause abdominal discomfort, which is kind of funny because it helps with nausea. Burning sensation of the throat, gas, may increase bile, so use caution with all stones. And no definitive interactions with medications, but it may interact with anticoagulants. That was from the CDC.
Yeah.
It seems like all of them
Interact with the anticoagulant, yep.
So these are like the chemical forms that are in ginger. And so yeah, they help and get rid of the oxidants, antimicrobials, anti-inflammatories, anti-cancerous activities for the Paradol. And then it's a root, the root part of the plant. Next slide. Okay, so it just, and then, yeah, the doses just depend on what you're trying to treat. So with menstrual cramps, they say 500 to 2,000 milligrams during the first 3 to 4 days of the menstrual cycle to help decrease the pain. And then osteoarthritis, 250 milligrams of a specific ginger extract called the Zintona EC. That one is more for knee pain, I guess, but you could probably use it for any osteoarthritis thing. Anyway, yeah, to help with nausea and vomiting, but the most important part is to not consume more than 4 grams of ginger a day. Next slide. And like Jaden had mentioned, these are some of the forms and formulations. It's used as a fresh or dried root in cooking. You can take it as a tablet, capsule, in cheese, and as liquid extracts.
Alrighty, so for our activity, we're going to have you all come up with a potential test question regarding ginger. So share it in class or write it in the chat if you're online. That's too hard. What was that, Amy?
What forms of cancer does it prevent?
Ooh. I don't know.
Put on the easier side and
It
say,
is easy. Yeah.
What does it treat? How about it can help nausea when
yeah,
pregnancy,
that's what I was gonna say.
sickness,
There we go. Probably
during
There we go.
Studies have shown
Maddie, that's a good one.
ginger
Anticoagulants.
anticoagulants
There you go.
or
Yeah, adverse effects. That would be a good one.
nausea. Especially for nausea.
What kind of discomfort can ginger cause?
Yes. Heart.
Well, depends on what you're trying to treat.
Okay, that's good. Thank you.
me to share the screen so you can go back. There. Yeah. Oh, never mind, it worked.
It worked.
It worked.
And then go back to the.
So then, yeah, you can go back so that it shows. Yeah, that one's. There you go. Okay, Shelby, Leslie, and Emily, you're up. I think they're all online.
Good morning, everybody. Okay, so I'm just going to start it out. So we have a presentation on peppermint. As you all can see, can you get the next slide, please?
Yeah, try and speak up.
Oh, can you not hear me?
Yeah, now we can.
Okay. So peppermint, an overview of peppermint. So a peppermint is actually a cross between two types of mint. It's between the water mint and the spearmint. The active ingredient is menthol, and it's the main ingredient found in these leaves, and that's what causes the effects. It's used for health purposes for several thousands of years. Ancient Greece, Rome, and Egypt use these for digestive disorders. And they have like scripts written of them where they would like prescribe them. It's actually pretty cool. Peppermint oil is available in gel, water, cream, and breastfeeding women can use it to provide relief in pain and cracked skin around the areola or the nipple. Common fave flavoring with many foods, I'm sure you guys know, especially coming up with Christmas. Can be used. It's fragrance, soaps, and cosmetics, and it is an herbal supplement. Next slide, please. So the history of peppermint, it was first cultivated in England in the late 17th century. It's been used for indigestion, like I stated recently, with ancient Egyptian times. It was found in Egyptian pyramids going back to 1000 BC. Roman and Greeks believed it soothed the stomach. I'm sure they were having lots of stomach issues back then. In the 18th century, Western Europe used it for menstruation pain, vomiting, nausea, and respiratory infections. Next slide. So general uses for peppermint, it's a broad herbal supplement, I believe, but specifically it focuses on digestion. Irritable bowel syndrome is one of the most common that it's used to provide relief for. They usually use an enteric-coated capsules to improve the absorption in them, and it can relieve like cool skin and relieve itching. I stated previously, can relieve pain for breastfeeding women in the nipple. It's used in fragrances, foods, and I also usually use it for like sinus infections. Like if I'm congested or anything, I'll just put a little bit in under my nose, and it can relieve my congestion just by like dilating the sinuses, you could say. People use it as a home remedy to repel bugs, headaches. I know a lot of people use it for, and in hospitals, nausea. We use it quite a bit in my on my unit if we have any nausea with patients. Okay, next slide.
Okay, can you guys hear me? Okay. So it comes in different forms. Fresh or dry leaves, those are normally used in tea to flavor your tea. And then essential oil, super huge, like doTERRA uses it. All of those essential oil companies have peppermint, and it's the most common. They'll use it directly on the skin, on the tongue, or they'll also put it in creams. And then the oils actually also put in capsules, like Shelby mentioned, the enteric-coated capsules that help it pass through the intestine. And then everyone's had like peppermint flavored candy. So the dosing, you don't need very much of it to have an effect. In adults, it's 0.2 to 0.4 milliliters, and that's in each capsule. And then in children, you don't want to use it in children younger than 8. But in children 8 years and older, they have 0.1 to 0.2 milliliters 3 times a day. They can have that. Next. And then the side effects. So really, like when I was looking at the side effects, it didn't seem like there was honestly like a whole ton that a lot of like research has been found on, but eye irritation was a big one, which is funny because I actually saw a video today of a kid who thought that these drops were eye drops, but they're actually peppermint drops, and he put them in his eyes, and they were like so red and irritated. I felt bad. And then skin irritation, flushing, so the cheeks going red, anal burning. That's gonna be like if you take a pill, right? Heartburn, nausea, and then it's rarely found to cause an allergic reaction, so they don't really worry about that with peppermint.
Can everybody hear me?
Yes.
Okay. So some contraindications and cautions is obviously you don't want to give it to children that are under 8 years old. Some of the sources that I found said that it can actually cause respiratory depression. You want to make sure that you wipe off the peppermint before you breastfeed. It's unknown what the long-term safety of consuming large amounts of peppermint is. Be cautious when you take antacids because it can break down the enteric coating. It can cause skin irritation and sometimes allergic reactions. It can be toxic in excessive doses. And then it's also contraindicated with hiatal or hernias and moderate to severe GERD because it can exacerbate the symptoms. And then some drug interactions. So any drug that's broken down in the liver, taking peppermint and a medication broken down in the liver can increase the side effects or the effects of the medication. And so these are some examples of medications that you'd want to be careful with. So like Zofran, amitriptyline, omeprazole. It interferes with iron absorption. So just be cautious if you're on any prescribed medications. Talk to your healthcare provider if you're wanting to take peppermint. And then for our learning activity, because the holidays are right around the corner, here's just a little recipe for some peppermint cookies. And then just tell us one thing interesting that you knew about peppermint or one thing that was new to you. And you can either type that in the chat or share in class.
It was for nausea.
And I knew it was good for headaches.
I did not know that it caused anal burning.
The things you learn in pharmacology about anal burning, right? So just a side note for this, and we're going to be talking about GI issues, but peppermint is something that a lot of people use to try and fix their GI issues like gallbladder and stuff. And so they get kind of addicted to it a little bit, and it's not just the candy. And so one of the post-op teachings is no peppermint after gallbladder and GI surgeries.
Okay, perfect. Yep, that's our presentation.
Yay!
So I want to know who's going to make those cookies and bring them next.
Yeah, who's going to bring the cookies for next week?
I vote Debbie.
Oh, thanks. All right, I'll have to go in and see what it is, what it takes. I think it looks like it takes more of the peppermint candy, I'm believing. But has anybody made those yet, or at all? Have you ever made cookies like that? Peppermint candy. Okay, hang on here. Just a second. Hang on for just a second. Okay. All righty. Can everybody see that online and in class? Obviously in class. So I will look at the chat. I mean, Corby will be here for a couple minutes and she's going to take off. I'll look at the chat in between breaks. So if you have a question in the chat, that's when I'll answer it. If it's something that's an absolute burning question that can't be answered, and then just chime in, okay? So far, everybody did really well. Most everybody did really well on this test. We have highs of 58, I think. I don't know, there could be a higher one than that, but so you guys did really well. Excuse me, we'll have that out. All righty. We're going to talk about GI disorders today. I know you're all excited. This is also a really straightforward unit. I'd like to get to the point where we have time to review at the end and kind of go over some things that maybe we didn't address. We're going to be in chapter 16, pages 218 to 220, chapters 42 and 43. And we're going to kind of go back and forth, but I put page numbers to kind of help reference. Okay, so let's go over our learning objectives. And someone gave me a really good idea of how they study. It was in a PN1. They have their learning objectives on one side, and then as they take notes, they put it down into what objective that is. So it's just throw it out there. If it works for you, great. It helps you study. GI is a very straightforward unit, similar to antibiotics. So we're going to talk about the pathophysiology. We're going to look at the classifications of medications. We're going to analyze the mechanism of action, also known as the mode of action, the side effects, adverse effects, contraindications, nursing guidelines for administration, and that's in those purple boxes in your book. I just wanted to just kind of give you a little heads up. As new nursing students, you highlight everything. But the only things that are really, really important in those nursing boxes is the ones that have the little lightning bolt in it. Okay, do you know what I'm talking about? You've seen them? This is when you shake your head, yeah, no? Okay, yeah, so just really concentrate on those ones. Those are the most important ones. And teaching measures for patients regarding medications. Okay, so those are the objectives. Every question you have on the test, every slide is going to fall into one of those objectives. Okay, that's what we teach to. All righty. So let's start about the gastrointestinal tract. I've reviewed the PowerPoints that you've had with Vicki and Chantel this week. And so I've kind of put in a little bit of pathophysiology to supplement that so that it's complementary for you. Okay, so this should all kind of gel. The digestive system breaks down food, it absorbs nutrients, and eliminates waste. That's its whole purpose. Okay. And there's two basic anatomic divisions. One is called the alimentary canal. It's a tube that basically goes from your mouth out through the anus. That's where the anal burning comes in, right, Kim? And it's continuous. And the other ones are accessory. I love teasing her. The other one is accessory organs, which include the salivary glands, the liver, the gallbladder, and the pancreas. All of those accessory organs secrete enzymes that help in digestion, and they break down food. All right. So the overall purpose and function of the system is to extract the nutrients. Most of that does not happen in the stomach. The stomach secretes enzymes that break it down. We'll get to that in just a second. So it's food, food is complex, and it takes multiple steps for the body to extract the nutrients that it needs. Okay. Ingestion takes food into the body. Some patients, some kids especially, they can't, their texture, they can't swallow it. And so it bypasses the stomach and goes directly into the small intestine, which is where they get their nutrients. You've seen them. They're called JPEG tubes or J tubes, PEG tubes, feeding tubes that go directly in there, okay? And then propulsion, and this is when substances are propelled along the GI tract by peristalsis. You've all experienced that if you've ever had abdominal cramping, okay? If you've had the stomach flu, you have felt that intense pain is the peristalsis, the squeezing of those muscles that are like, get the H out of here, and it goes in a real quick way. It's also mechanical and chemical. We just talked about the mechanical, and then the chemical is the enzymes that are absorbed into the systemic circulation. There's a large number of enzymes. They're secreted by the salivary glands, the stomach, the small intestine, and the pancreas. So it starts to chemically break down the moment you put it in your mouth. Your spit, for want of a better word, the mucosal saliva that's in your mouth starts to break that down. This is kind of review. Is it kind of coming back to you from pathophysiology and from anatomy? Okay, the liver makes bile, which is stored in the gallbladder until it's needed for lipid digestion. Absorption is the movement of nutrients and other substances from the alimentary canal to circulation. That's where it happens in the bowel. This is a cross-section of the villi that's in the bowel. This creates huge amounts of absorption and surface to be able to have that pass through. That's where it goes from the tube into the circulation. Okay, so the small intestines lined with the little projection called villi, and then defecation is the elimination of indigestible substances from the body, commonly known as poop, fecal matter, and Rachel is all about this, right? And so the upper GI tract that's divided into two from the duodenum up, okay? So from the mouth all the way down through the stomach enters into the duodenum. Right there is where it ends from the upper GI to the lower GI, okay? And from a pharmacological standpoint, the buccal and sublingual areas of the mouth and stomach, they are where we put medications. What medication, just a couple of weeks ago, goes under the tongue that helps dilate blood vessels for people that are experiencing chest pain? Yeah, nitrates, nitroglycerin, okay? So that's an example. It goes underneath and it immediately, the mucosal, the saliva starts breaking that down and it goes right into the system. We're going to talk about medications today that do the same thing. One of them is called Zofran, ondansetron. Okay, it's the same thing. People are throwing up. The last thing you want to do is swallow a pill with water. Okay, so this is where we're able to put it underneath the tongue or in the buccal area behind in the cheek and the lower, especially if you're a kid, that you can get that in there. It starts to work because it dissolves. Okay, so sublingual medications, do you ever chew them? No, they let them dissolve. And even though they may taste kind of, you still say, let it dissolve. Okay, questions? We'll go on. Okay, so the pharynx and the esophagus serve as passageways. You know that. You eat it, it goes down. Sometimes it doesn't go down, and that's when you have to head to the ER, right? Chew your food. So the stomach has both mechanical and chemical functions. Okay, it squeezes, that's the muscular. The chemical is it turns it into a substance known as chyme. CHYME. So that's why when you throw up, it's kind of liquidy, or if you're there when someone is throwing up, sometimes they will throw up undigested food. But most of the time it's in some form of a liquid, kind of substance. Okay. And then you have strong peristaltic contractions that push the chyme towards the pylorus. It's important to note, and I'll just kind of notate it right here. You've got two sphincters. This one is actually at the top of the stomach is actually called the cardiac sphincter. I know it's kind of, wow, okay. But it's kind of close to the heart, believe it or not. The one down here is called the pyloric sphincter. If these don't work right, you have problems, okay? And we're going to talk about when they don't work right and what happens in that situation, okay? So the physiology of the upper GI tract, the hydrochloric acid that's in the stomach, which breaks it down, has a pH of 1.5. Is that acidic or is it alkaline? Acidic, thank you. Yeah, it's super acidic. And it is horrific. So the body doesn't like to be in an acidic state, yet look, we have a 1.5. There's some other things that the body does to kind of help protect it. when you think about tissues and you have a pH of 1.5, those tissues would be destroyed like within minutes if the body didn't have some sort of protective mechanism. Okay. For the most oral drugs, the stomach is not the primary site of absorption, again, because it breaks it down and it gets it out of there quickly. So that's the reason why it does not stay long in the organ. The stomach acidity can either assist or it can destroy. And this is where I want to just kind of do a small little review about people that have difficulty swallowing. A lot of times we crush up their pills, or we'll put them in a little bit of applesauce, and that helps them swallow. What kinds of pills do you not crush?
Or extended release.
Okay, so there was an enteric coated, I heard extended release, and we're missing one other. Sorry, let me try the chat. If you're in the chat, chime in. Capsules. Capsules. Especially if they have little beads, because those beads break down into the small intestine. There are some medications, and we'll go over those today, that you can break down, okay, that you can smush. But for the most part, enteric means it's coated so that it doesn't break down in the stomach. Now, when we raise the pH level, when we're talking about heartburn, when we're talking about antacids, which we're going to all talk about today, it raises the pH and it can actually start to break down that enteric coated medication. So those are kind of some of the things to keep in mind when we're talking about the GI system.
Does the combined secretion of the chief and cells known as blank?
The chief and parietal cells. I think it's called like hang on. Yeah, the very odd. So you've got parietal. The most important thing is just the chief and parietal cells. Okay, because the chief and parietal cells are the ones that secrete the acid. And that's what we're talking about today. Okay, so chief and parietal cells. There is no question on the test about pathophysiology of chief or parietal cells. This just helps you understand where the acid comes from. Okay, and it comes from the mucosal lining, the little dents or the little depressions in the stomach, as of this picture, where those cells are. And those cells are always reproducing because they continue to die and they are replenished. And so the medications that we're going to talk about is going to talk about decreasing the amount of acid that's secreted. And so when we talk about proton pump inhibitors, when we talk about H2 receptor blockers, which we're going to get to today, this is where they act on, okay, is these cells that prohibit them from secreting as much acid as they normally would. So it's just important to know these are the cells we're talking about that the medication is affecting. Does that make sense? Does anybody have the chat up? Enteroendocrine cells, that's the last one. It's at the bottom of this one, the enteroendocrine cells. But you don't need to know that. Does that make sense? Okay. All right. So now let's talk about the physiology of the lower GI tract. Okay, so the small intestine is the longest portion and it's the primary organ for absorption. That is something that you need to know. Okay, it's the primary organ for absorption. When I say something is important, it's either a test question about it or you need to know it for your nursing practice. This is a nursing practice question, okay? Because people are going to say, well, where does this drug work? Okay, it's just straight across. Most of them are in the small intestine. Okay, the liver is the most important accessory organ because it regulates glucose, triglycerides, cholesterol, removes toxic substances, synthesizes bile, and stores iron and fat-soluble vitamins. If you remember a couple, sorry, is somebody chiming in? Oh, okay. If you remember a couple of weeks ago when we were talking about vitamins and the fat-soluble vitamins, and I told you that there was a patient who thought, well, if juicing carrots is really good, then that's all he should do. And over the course of a weekend, that's all he did was drink carrot juice after he had ground up the carrots. And he died. He died because of liver. It was too much for the liver to handle. He literally died orange. And so that's why you got to be careful with those fat-soluble vitamins. There's too much is not good. And the liver takes the hit. Okay, so digestion is regulated by numerous hormonal and nervous factors, okay? So it controls the speed of peristalsis. It's influenced by the amount of saliva. Parasympathetic nervous system stimulates the digestive process. The sympathetic nervous system slows the digestive process. And the GI tract functions at an anatomic level. You can't tell it what to do and how to do it. It just automatically does its thing. There's some people, this is the reason why, what's normal for a bowel movement? Well, some people, it's 2 or 3 times a day. That's normal for them. Sometimes it's 2 or 3 times a week, okay? It just depends on the individual, and it just depends on what their system is, okay? We good? Okay, so these are the things that we're going to talk about today. This is how the rest of the day will flow. We're going to start at the top. We're going to talk about nausea and vomiting and motion sickness. We will move to ulcers. And ulcers, we're going to talk about those that are in the stomach and gastric. And remember, ulcers is like a lesion or a sore, okay? Then we're going to move into the lower GI tract and talk about diarrhea and constipation. All righty? So let's start here with the nausea, vomiting, and motion sickness. All right, so this is page 218 to 220 in your book and chapter 42. So if you have that, open it up so that you can kind of review it. All right, antiemetics. So when you throw up, what is that called that actually comes out? Emesis, okay? And so do you see where it says like antiemetics? Okay, anti meaning opposite of, emetics, emesis, the opposite of emesis, okay? They're prescribed to treat nausea, vomiting, and motion sickness. All righty. So I'm hoping that this will work. Here we are. Hang on. Oh my gosh, really? Just a second. Whoa, whoa, whoa. I had it working at my office today, so I'm going to copy this link. Just a second. Ooh, ooh, wait. Sorry, it's a really cute video on why we get motion sickness. Hang on, let me. Oh! Hang on. Just a second. Time out. Go to the bathroom. Man. Yay, Mapu, you're right. She had capsules. Hang on, let me just copy this. And everybody's like, okay, I'm going to die. All right.
So, you've just begun your road trip with some friends when you decide to read a book in the back seat. But after only moments of reading, you start feeling dizzy, fatigued, and nauseous. Sounds like motion sickness. The surprising truth is that about 30% of the population experiences motion sickness, with over 66% of people
I'm now unmuted. Okay. Let's go back to, wait a minute. All right, sorry. Okay. Oh, no. Hang on here. Holy smokes. This is what I need, Corby. Or one of you really smart people. All right. Have you ever traveled? Has anyone ever traveled on an airplane or anything and somebody's gotten sick? What was it like? Say it loud.
It was terrible.
And why?
I felt like I was like sweaty and nauseous. I felt like claustrophobic, and I just wanted to get home.
Okay. And so you were the one that got sick, or you were around somebody that got sick? You did. Okay. All right. Anyone else? Anyone else?
Are you good?
Oh, I am now. See, you just show up. I'm like, this is what I need, Corby.
I came running.
And you came running. That's awesome. She's awesome. Do any of you get car sickness? Like, okay, what happens when you?
My head feels icky.
Okay, your head feels icky. Kenna, you say you throw up.
I feel like I'm in the frog.
Okay, you get nauseated. Yeah, yeah. And again, it goes back to that video because your ears are saying you're stationary, you're good, you're in the car, but your eyes are something. Your ears detect the movement. Your eyes are like, no, you're good, you're in the car. And it's when those two signals don't mesh in your ears that there's a problem. And if somebody throws up by you, do you throw up?
Nope.
Do you get sick? Nope. That's because you're nurses. Yeah. So we treat motion sickness with anticholinergics, okay? Specifically scopolamine. Scopolamine is a patch that goes behind your ear, and it can last, you can keep it up for 3 days, okay? A lot of your pilots and other people, if you fly, just take a look behind their ear, if they've got short hair, you'll see a lot of them will have patches behind their ear. And we also treat it with antihistamines, which is diphenhydramate, which is also known as Dramamine, and meclizine. This is a great drug. This is now over the counter. It's also known as Antivert. It's also known as Dramamine less drowsy. I thought that was kind of interesting. Okay. It's also used to treat signs and symptoms of vertigo, which is inner ear infections. Do any of you have families that have inner ear problems? You have inner ear problems. It's legit, and you can get viruses in there, and people come into the ER because they're like, I'm so dizzy, I'm sick to my stomach. There's a difference between dizziness and vertigo, and this is not on the test. It's just strictly FYI because you're going to get people that are dizzy. So when a person comes in and they have dizziness, nausea, vomiting, I ask them a question and I say, are you dizzy or is the room spinning? Okay. If they're dizzy, that's dizziness. It's lightheaded. It's usually associated with some nausea. But if they say, every time I open my eyes, the room spins, that's vertigo. Okay. Yeah. Yeah, that was last night, right? And that's where inner ear comes in. These are all over-the-counter medications, and there are questions on the test regarding scopolamine. Okay? FYI. All right, so these are side effects that are related to anticholinergic. Mark, I know you know this by heart. What, besides reading, what are some of those that you know about? Of side effects of anticholinergics. Mark has a picture that he has memorized, right? That is cholinergic, anticholinergic, what it does, and this, that, the other. That's what Vicky said. That's why he's rocking 90% or on his chest. So what she said. What do you think? Go ahead and read. Here. And I will toss one to you.
Dry mouth, constipation.
Urinary retention, dizziness. The things that are most common in anticholinergics. Did I not get it? Contraindications, glaucoma. Nursing guidelines. So when you know you're going to take or go on a trip, do you take, Kenna, when you get sick to your stomach, do you take anything before you get on in a car or airplane? Nothing.
No, I just don't study while I drive.
You just don't study. Do you sit in the front seat? Sometimes. Yeah. I have kids that get really, really car sick. And so they have to be in the front seat. And I'm giving them Dramamine or Meclizine before. It's most effective 20 to 60 minutes before you travel. So if you have someone that you know gets sick, make sure they take something before they get in your car. At least an hour, about an hour. Okay? That's important to know. That'd be a great test question. All right. So we are going to play Poll Everyone again. This time it's going to go a little slower. So get out your phone. This is part of your learning activity. So people that are online, please just grab your phone and go to the website. Or see at the top where it says pollev.com/Deborah, DEBORAH, EVERE 759. Everett is my last name. Yeah. So it's my first name. Yes.
So none of your slides have progressed since the YouTube video, so we can't see the slide that has the polling.
Okay. I'm sorry. Hang on just 1 second. Thank you for letting me know. And here's Corby. She knows that.
You need to stop sharing.
She's watching.
I'm watching.
She's watching. She's
No.
my
Where's
big
your-
brother.
Here it is. So you just go here to stop sharing external.
Oh, I did stop sharing. So I'm so sorry online. If you were here, you could have treats. I brought pretzels and cheese. Corby's fixing it. Hang on.
Maybe. Let's see. Which one is it?
Yeah.
That one.
Okay, Mark, you're in charge of passing these all out. How are you at basketball? Can you?
I am not a baller, but
You're not a baller.
all
Oh, good job. I'm thinking you are. Give me a ginger.
Yeah, I mean, hitting bricks a lot.
Okay.
Yeah,
Let's see.
That's mine.
I did watch it. This has not enough power on it. What's the hand? Megan, you want it?
There we go. Okay.
Go Dodgers.
Do you want to? Can you hang out for a second just to make sure?
Yeah, go Dodgers.
It does. All right. Okay, so online, can you see this now? Stephanie, can you mic in, please?
Yeah, we can see it.
Okay, great. Is everybody able to log in and get to this question? Can everybody see this question? Okay. Thank you. You're the best. Okay. Go ahead, read the question, answer it. Okay. Go ahead. It's just only letting you do one. Okay. It doesn't let you? Okay. Sorry. Yeah. All right, so which ones do you think are correct? Sorry, I guess it won't let you do more than one. Sorry, this question's like totally screwed up. I apologize. All right, so which one do you think is correct? There's several. All right, so the patient's prescribed a scopolamine patch to prevent motion sickness. What teaching does the nurse give about this medication to the patient? So select all that apply. That means more than one and not all of them in this case. This medication will make you urinate often. Is that true or false? Okay, it's false. It's an anticholinergic, so it will have urinary retention. Place this patch behind your ear 60 minutes before boarding the boat. Is that correct? Yeah. It doesn't matter whether you're going on a boat, a train, a plane, car, put it 60 minutes. That's right. This medication may give you dry mouth. That's a true statement. Because you may urinate often, eat foods high in sodium. Okay, that would be not true. Yeah. This medication may make you sleepy, so be careful on the ship. Okay, that's true. It may make you drowsy. Dramamine can make you drowsy. Antihistamines can make you drowsy. You don't have to change this patch for 3 days. That's true. That's true. You don't need to do it. And in really severe cases of nausea and vomiting, especially in surgery, they'll do one of two things. They will either use a corticosteroid like dexamethasone, also known as Decadron. If you have the opportunity of going in the OR, I don't know, some facilities are different, but I know if you're at Davis, you can actually go from the pre-op with the patient into the OR and in the patient in PACU. In PACU, they use Decadron a lot. If it's really severe, I have a daughter that throws up for 3 days. They put a scopolamine patch on her in the pre-op. So one of those two things. There is a test question on that, and I would vote more towards the corticosteroid. All right. Okay, pathophysiology of nausea and vomiting. Vomiting is a reflex primarily controlled by a portion in the medulla known as the vomiting center. So if you look here in this picture, it has the vomiting center in the medulla, and right next to it is a chemoreceptor trigger zone. So the chemoreceptor trigger zone, or the CTZ as opposed to TMZ, it has drugs, it picks up drugs and toxins, all right? They're right next to each other, and right next to that is the vestibular center. That's where your inner ear is, okay? That's the reason why these things are all connected. Sometimes you get receptors from the stomach, from the vomiting center. Sometimes you get chemoreceptors, and sometimes it's right next to the vestibular, so if that one's acting up, and it causes everyone, not everyone, a lot, to vomit, okay? The important thing for treatment outcomes is that it focuses on removing the cause, whatever is feasible. There is actually now a new syndrome from smoke and weed, and you throw up and you cannot stop. And the more that you smoke it, the worse it gets. And it is really tough. They come into the ER because they're just throwing up. And we hit them with the medications that we're going to talk about today, and it doesn't work because it's the chemoreceptor that's still in the body saying this toxin is still in there. Okay, so I know, it's great. Nausea and vomiting is experienced during the first trimester of pregnancy. Is that true, Braden? Jada, sorry.
It's true.
Braden is, where's Braden's at? It is true. Yep, it is. And there is a really serious thing. A very, very famous person gets this every time she becomes pregnant. It's called hyperemesis gravidarum, okay? So it's where the health of the mom and baby can be at risk because they don't stop throwing up. Who do you think it is? Kate Middleton, Princess Kate. Yeah. She gets it. Yeah. She gets it every single time. They've gotten better. So she's like basically hooked up to an IV the first 3 months of pregnancy. And now they've kind of done it. Now she's in her palace that they do it. They did take her to the hospital the first time. And somebody, did you know about like the nurse that killed herself from this? So we talk about HIPAA. We talk about not releasing information. So one of the paparazzi or whatever was posed as a family member on the phone and asked how she was doing. They kind of had some inside knowledge of what was going on. And she said, oh, well, she's resting comfortably. We're giving her medications, blah, blah, blah. And this was a paparazzi dude that then published it throughout the UK in the newspaper. And the royal family was ticked, obviously. And the nurse was so upset that she had done this that she committed suicide. And Kate and William were so upset that this had happened in terms of, her committing suicide. And it was like, people, give us some privacy here. And so ever since that time, every time she gets sick, they just treat it with IVs in the royal palace. Just FYI. Okay. Anti-neoplastics down at the bottom can cause nausea and vomiting. Anti-neoplastic are chemotherapy. Okay, these are cancer drugs. It doesn't matter whether you take a pill or it's in an IV or through a portacath, they cause nausea and vomiting. That goes back to the triggers, the drugs and the toxins that are in the chemoreceptive zone. Okay, so there are non-pharmacological measures that you do. These you do first before you do any kind of pharmacological treatment. You do non-pharmacological because you have to know what are we treating. Remember, that's the most important thing. Most important, what are you treating? Okay. And we'll have people that will come into the ER and they're like, I've been vomiting for an hour and a half. And I'm like, okay, so, have you tried some clear liquids? No, I've been vomiting for an hour and a half and I want it fixed now. It's like, oh, okay. These things need to be tried. Page 605 is where you find these non-pharmacological measures. Okay. There are test questions. Yes.
I have a question.
Sure.
Wouldn't IV fluids be counted as a medication?
Yes. Yes. It is classified as a medication. Okay. But an IV fluid is not the same as like Zofran. It is a medication. You're correct. It's not in the same category as like Zofran or scopolamine or other things that specifically act on the vomiting center. IV fluids are simply trying to rehydrate.
So on the test, it would be IV fluids would be a non-pharmacological measure.
In your book, let's turn to page 605. You don't have your book. In page 605. On it says non-pharmacological measures. It says it includes weak tea, flat soda, gelatin, Gatorade, Pedialyte, crackers, and toast may be helpful. When dehydration becomes severe, IV fluids. Does that make sense?
So the reason why IV fluids is counted as a medication is because pretty much anything that requires a prescription or a doctor's order is medication. Like, honestly, oxygen is considered a medication. Yeah. But now, non-pharmacological, though, it's not necessarily a pharmacological intervention. Does that make sense?
Yes. Can somebody look at the chat?
It's just hydration. It's not like an actual pharmacology med. Does that make sense?
Did you hear Corby?
Yeah, it kind of makes sense.
Yeah, so it's strict. IV fluids are strictly for hydration, and because it requires a doctor's order, it's under medication. Just like oxygen requires a doctor order, so it's classified as a medication.
But
it really
not. It's
isn't.
just for hydration. It doesn't do anything to your body to alter it other than hydrate it.
So are doctors considered drug users when they
Okay. Can we continue, or are we clear, or are we not clear? Are we clear? Okay. All righty. So these are the classifications of antiemetic drugs. You need to know the classifications of the antiemetic drugs. There's 9 of them. And in the succeeding, in the following slides, I give you what they are in each of those categories. Okay? Tried to make it helpful. Go ahead. You bet. We can certainly do that. Okay. 10 minutes. 11 o'clock.
I don't know. I mean,
I just want to miss it.
I don't care.
Just not doing anything today. I'm just exhausted. You guys spend
I'm pissed off my days.
Yeah, that too.
Still feeling drawing. Same with you, Jake.
Yes, Megan, it's like how oxygen is technically a med. Okay. So I'm just going to go through the chat here and see if there's any questions. Okay.
Yeah.
Emma, you need to get a scopolamine patch if you throw up on every flight. Bless your heart. And your husband's a pilot. See?
Well, my average is still 79. It's already, wait, you filled this out or it's already filled out? It's already This filled test out. brought mine. It's not like 80. Oh, yeah.
So sorry. Flat soda would make you barf, Jennifer Jensen. So they're in Coke syrup. Coke syrup actually kind of calms the stomach. So if you let the Coke, real live Coca-Cola, get it flat. Okay. Toothbrush and toothpaste. Good job. Good job. Yeah.
Only Mama Chels left some from last night.
All righty, so I'm going to mute this. We're going to stop recording, and then we'll start it back at 11 o'clock, okay? Are you sure you want to pause this? You can resume by selecting the record mode. Yes, I can. All righty. Okay, it's 11 o'clock. We're going to get back. Looks like people are back and ready to go online. Hopefully I can get this back here. All right. Okay, so if we can continue on. Just kind of waiting back in the back. Thank you. That way I don't have to scream. Okay, so we were talking about these 9 categories of antiemetic drugs. You do need to know them, okay, because there are questions on them, all right? You don't need to know every little thing about them, but you do need to know the classifications and what you would do for teaching based on what they are and where they're used from. Okay, so here we go. Okay, the first 2, anticholinergics and antihistamine, and they're used, so this would be, why they're used for nausea, vomiting, related to motion sickness, okay? This is how they act. They act on the vomiting center to decrease the stimulation of that chemoreceptor zone and the vestibular pathways. The most common we talked about, scopolamine. And in the antihistamines, this is review, diphenhydramine, meclizine. Okay, they're also very effective. So that's the first 2 classifications, guys. Okay, basically a couple of drugs that we've already talked about. Then we go on to the dopamine antagonist. Okay, this includes phenothiazines and benzodiazepines. They act by blocking the dopamine receptor in the chemoreceptor transmitting zone. Promethazine is one of the prototype drugs, and this is the difference between when this book was published, which was just a few years ago, and the way it is now, okay? Because promethazine was a medication that was used for years. And the problem is that they found that when it's given IV, that you actually sclerose, you kill the vein it's going into. So it's now changed, and IV medication, IV promethazine, is a super duper high risk medication. It's diluted. We used to be able to just, mainline it. It comes up from the pharmacy. You have to sign for it. I mean, there's this big thing, and you have to have a large bore IV, which is an 18 gauge. It has to be in a big vein, usually an antecubital. I mean, it's all this stuff, okay? So, but it's still used. Promethazine is still used in either the PO form or there is a suppository. Because again, remember, you're throwing up. You don't want to be putting stuff into your gut. So that's where suppositories come in. It is sedative. It makes you go to sleep. Okay. And then we also use drugs that are normally used for antipsychosis, for antipsychotics. When people are in a psychotic situation, haloperidol and droperidol. Okay, it's also known as Haldol. But if you use them in teeny tiny little amounts, they will help with nausea, vomiting, because they affect this center, the chemoreceptors. Okay, and they're used a lot in chemotherapy. Okay, in cancer, chemotherapy is like its own world, but they use a lot of them. Okay, so those are the only ones that you really kind of need to know about. They make you sleepy. They can cause phlebitis if this is used IV, okay, the promethazine, and they're a dopamine antagonist, all right? Then you get into the benzodiazepines. So lorazepam, what's lorazepam kind of also known as, for those of you who are med techs? Or Ativan, yeah. How many of you have, given Ativan in a pill form? Okay, it's used for anxiety, right? Kind of relaxing. There's times in the ER that I say we need Ativan misters around here, so it just kind of like brings Ativan down, so everybody can kind of calm down. It relaxes people, but it also works really well for nausea and vomiting when it's related to chemotherapy. Yes, Mark.
So it says,
Nice and loud so they can hear it.
so for dopamine antagonist, it has benzodiazepines, but benzodiazepines is also a category.
Yeah. The reason because it's still benzodiazepines work as a dopamine antagonist, but I wanted to separate that out because there was a specific medication that's on your list, and I wanted to make sure we went over it in its own little category. Does that make sense?
Yeah, I just want to make sure.
Yeah. So it includes a dopamine agonist, includes those three things, but I wanted you to know about that specific medication of the lorazepam. Okay. And its main use, again, is either to relax or decrease anxiety. Because remember, have you ever, like when you're doing your presentations, do you ever get like butterflies in your stomach and you're like anxious and your stomach hurts when you have to present or when you have to give a talk or anything like that? It's the same thing. When people are having nausea and vomiting, their stomach just hurts. And so this is a drug that's used to help with that, but it does it because it affects the chemoreceptive trigger zone. And a lot of times they use it with a steroid, with a glucocorticosteroid. Again, chemo. All right, 5, this is where you live and breathe, okay? The serotonin 5-HT3 receptor antagonists, okay? And I usually just say serotonin receptor. They act by blocking the serotonin receptors in the CTZ, and they block the vagal nerve terminals in the upper GI tract. And a few slides from now, you're going to see where there's an actual image of how that goes down. Ondansetron, which is also known as Zofran, works well this is in the category. This is where you live and breathe. How many people have given Zofran? Either IM, PO. Next semester, when you get into RN3, you're going to be giving it IV. This is where you live and breathe. The most of them all end in tron, that are in the serotonin, end in tron. Okay, there's the last name. That's also a key, so that if there's a test question and it has, you know, a tron, oh, okay, that's serotonin. That's nausea, vomiting. It works well with pre and post surgery, as well as chemo-induced nausea and vomiting. Okay, and then this is the corticosteroids. Now, it sounds kind of weird that you would give a steroid for nausea and vomiting, okay, but it works, and it's thought to antagonize the prostaglandin or release of endorphin. And this is where it comes in really handy for surgery, post-surgery, when they're coming out of anesthesia, right? Have you anybody work OB and moms that have had babies, they just shake afterwards? It's the trauma of giving birth. And they'll give Decadron, and they'll also give Demerol. Most of the time, we don't ever use Demerol anymore, but they will, because that affects this release of endorphins, okay, from that. And the dexamethasone or the methylprednisolone are used to prevent, again, chemotherapy and post-surgical nausea and vomiting. That's a really good test question. So, you know, if someone says, gosh, I throw up every time I have surgery, what do you think they're going to give them? Well, because steroids last so long, Zofran you give about every 4 hours. What would be the best medication to give for the longest effect? Somebody look at the chat. Nothing. Okay. Steroid. The steroids last so long. Yes, Mark.
So if it lasts so long, why does it say for acute cases?
Because of the adverse effects of being on a steroid. So it's just getting them over that initial nausea, vomiting coming out of surgery or coming in chemo. They'll give Decadron, dexamethasone the day they get chemo. You know, right after they get chemo, they'll give it. They'll kind of preload them. Where Zofran doesn't work. I mean, it works okay for chemo a little bit down the line, but for dexamethasone, they hit them right there. They do that in post-op. They hit them right there to try and, especially those that are kind of starting to gag when they come out of anesthesia, they'll hit them with that.
So those are just going to be used for like one-time doses?
Yeah, just one-time doses. Yeah, just one time because of the adverse effects of being on a steroid. Does that make sense? If you're online, please chime in. Okay, cannabinoids. There is a root word here. What's the root word? Cannabis, okay? So this is what comes from marijuana, okay? It's given PO to produce the antiemetic effects and relaxation, less the euphoria that's compared to marijuana. You don't get the hallucinogenic effects of smoking weed. It's super effective in chemotherapy. Super effective. It's not as effective in other antiemetics unless it's chemotherapy, and it's contraindicated in psychiatric disorders. Why do you think that might be? Why do you think it might be contraindicated in psychiatric disorders? Yeah, it can cause the euphoria. It can put you in a psychotic event. Sure, exactly. Okay, there's only one drug. Yes, that's right, Marinol. Dronabinol is another one. Dronabinol. And then the other one is a miscellaneous antiemetic. And we use this a lot for a lot of different purposes. You're going to see this medication again when we start getting into ulcers, okay? But it's also used in nausea and vomiting. And that is metoclopramide. It's known as Reglan. And Reglan is used extensively in the operating room, in pre-op, okay? It also kind of dries up secretions. So you don't want to aspirate, so they use it then. We use it in the ER for headaches, for migraines. We use it for ulcers. We use it, again, give it before they go to surgery. It's also used in anti-ulcer. In this case, so it's an antiemetic and anti-ulcer, and it's under miscellaneous, okay? It's nausea, vomiting due to post-op and chemoradiation. Questions about any of these categories? They're pretty straightforward. Is anyone in the chat saying it's a problem? Contraindications for all of these classifications, all of the 9, all of them. GI obstruction, hemorrhage, perforation, and first trimester of pregnancy. There are some physicians who will prescribe Zofran in the first trimester of pregnancy. Yeah. It's coming down now that they're saying it's not safe to do that. Again, this is the world that you live in. This is the world of nursing. The only constant thing is change. Okay? As more evidence comes out, they'll change it. Okay, any other questions? All right, so here we are. I'm hoping this works. We're going to try it again. Let's get out your poll Ev. Log back on to Deborah EVERE 759 and take the question. This only has one answer, so hopefully it'll let you do one answer. Oh, it does? Yeah. Even after you refresh? Oh my God. All right. Is this question showing up online? Let's answer that. Somebody chime in.
Yeah, it's on the blue button.
Okay. Will it let you do it or not? Will it let you answer the question or not? Okay. So let's go over it. So a patient with nausea is taking ondansetron, also known as Zofran, which is a what? Antiemetic, and which class? Serotonin. Yeah, serotonin receptor. She asked the nurse, how does this drug work? Okay. The nurse is aware that this medication has which action? Enhances histamine 1 receptor sites. Do you think that's false or positive? It's false. Blocks serotonin receptors in the chemoreceptor trigger zone. Do you think that's false or true? That is true. That's what it does. Okay. Blocks the dopamine receptors in the chemoreceptor trigger zone. Is that true or false?
False.
It's false. This is what we call a dazzling distractor, guys. Okay. C is a dazzling distractor. It does not block the dopamine receptors. It blocks the serotonin receptors. Okay? And the D stimulates anticholinergic receptor sites. Is that true? No. Why is it true? Why is it not true? Why is it false? Because it is. I love it. Because it is. You guys are freaking awesome. Because you already selected B. That's right. Because it's serotonin. Okay. It doesn't stimulate a receptor site. It blocks serotonin. Okay. All right. Here's another one. When Reglan is given for nausea, the nurse plans to caution the patient to avoid which substance? Milk, coffee, alcohol, or carbonated beverages? Yeah. Yep. Take the alcohol. Yep. When in doubt, take the alcohol. Exactly. Yeah. Okay. Milk doesn't do anything to it. It doesn't inactivate it. Coffee doesn't stimulate anything. Carbonated beverages doesn't, but it does interact with alcohol. And you'll see that in your book. Okay. So these questions, guys, came from the end of the chapter questions in your book. They're word for word. Okay. All right. So on the opposite end of antiemetics are emetics. So these are things that make you throw up. Okay, we're just going to touch on it. I don't remember if there's a test question on it. I'll look in between the break. If there is a test question on it, we'll address it either in the clarification document or here today. All right, so these are things that induce vomiting. Okay, you never induce vomiting if a substance is toxic, like ammonia, chloride bleach, lye, toilet cleaners, battery acid, because of the pH. It is so acidic that if you try to get them to throw up, it burns it. And in fact, Vicki told me of a story where she took care of a little 2-year-old. Remember, her specialty is peds. She took care of a 2-year-old that had drank gasoline. And because of the burningness, they had to remove her entire esophagus. And she was taking care of this little tyke. Yeah. So, and again, the petroleum, paint thinners, lighter fluids. So activated charcoal is what we give when we don't want them to throw up, but we want them to, it absorbs. It's literally charcoal, okay? Ground into a little teeny tiny powder, and then it's mixed with a thing called lactulose, which is a laxative, and that's liquid dynamite. And they drink it, and if they don't drink it, we put an OG tube down, and we put a bite block so they can't bite the tube, because most of these are usually mental health related because they're trying to commit suicide. And we put it down in a 60 ml syringe, shove it down there, and then we get them to the floor very quickly because within an hour, they usually explosive diarrhea. And so we don't like to do that in the ER, so we get them down to the floor quickly so they can get to a bathroom. Question mark.
Yeah, I know somebody that overdosed on things like meth, heroin, a whole bunch of drugs at one time, and then they just gave him this.
Yeah.
Because he was out, they found him just out
in
the bathroom, passed out and everything, and they just give that.
Yeah. It's called activated charcoal. Yeah. So we used to give a thing called Epicac that induced vomiting, but again, evidence shows that's not good. What's good is to get this charcoal down, which really absorbs the toxins, and get it through the GI system as quick as we can. Okay. Like I said, I will look and make sure that if there is a test question on an emetic, I will make sure that it is addressed, okay? Either in the clarification document or today. Okay, good? Okay, moving on. So let's go through GI disorders for the stomach and gastric. This is ulcers. This is when things go wrong because of the acid in the stomach, okay? All righty. So there's two things that we're going to talk about, and you will see this all the time in your nursing practice. One is called peptic ulcer disease, or PUD. The other one is called GERD, which is called gastroesophageal reflux disease. GERD. Okay, peptic ulcer is caused by an erosion, okay, of the mucosal layer of the stomach, or the duodenum, from hypersecretion of hydrochloric acid and pepsin. Now, there are some people that say it's not duodenum, it's duodenum. Remember, we had this big discussion about angina and angina? I figured it out, did a little bit of research. The reason why we have the differences in the pronunciations is it depends on where you live. So in America, we call it duodenum. If you were in the UK and you're in Europe, they call it duodenum. Yeah. That's the reason. So, so in America, it's angina. If you're over in the UK, it's angina. Yeah, so that's the way it is. So it's okay. It's okay. That's the reason why we have the differences of it. So, all righty. So it's an erosion. So it makes a sore. In GERD, it's an inflammation or an erosion of the esophageal mucosa caused by reflux of gastric acid from the stomach. So this is when that cardiac sphincter isn't working and the acid comes up into the esophagus. We call that heartburn, okay? And we'll get more into this. Peptic ulcer disease, you need to understand, is a broad term, okay? It's a broad term because it means that it could be, there could be disorders in 3 or 4 different places, and it's all part of the peptic ulcer disease spectrum. Does that make sense? Okay.
Wait, so is GERD considered a peptic ulcer disease?
What?
Is GERD considered a peptic ulcer disease?
It is part of it, but not really. It's its own thing. Because it's specifically acid that goes into the esophagus. Where as you get into peptic ulcer, we'll see there's different spots. Okay? And here is the answer to your question, Mark. And a peptic ulcer is a lesion or an erosion located either in the esophagus, in the stomach, we call that a gastric ulcer, or in the small intestine, which we call a duodenal ulcer. The mucosa that is associated with acute inflammation. Okay, so you can kind of see here, here's where the esophagus is. Okay, so it's either inflammation or a lesion. If it's in the stomach, it's called what? Right there. Gastric. Okay, if there's a lesion or a sore, an ulcer in the stomach, it's called gastric. And if it's in the duodenum, it's a duodenal ulcer. Okay? Or the duodenal, yeah, that's what it calls. Okay? Peptic ulcer disease was uncommon in the 19th century. This is known as a disease of civilization. As we've progressed, as we've gotten more stressed, as we've taken more things into our bodies that aren't good, this now is huge. It's huge. It most often occurs in middle age. Sometimes it can be in childhood or infancy, but most of the time middle age. And it occurs when there's an imbalance of the protective factors versus aggravating factors. The aggravating factors are going to be the acid, a pepsin, and hydrochloric acid. And the protective factors are the mucus, the levels of mucus and bicarbonate that protect the stomach and the duodenum and the esophagus. Does that make sense? When you don't have this, there's a good balance. When it gets out of balance, when you have more acid and when you have more pepsin and you have more of these enzymes and less of the mucus, that's when you start to get sores. That's when you start to get lesions. Okay, and here's a picture. So this is the mucus droplet cells, okay? The parietal cells and the chief cells, they secrete this acid, but the mucus droplets secrete bicarbonate and mucus, and that's what protects the stomach. And so the juice, the gastric juice, which remember has a pH balance of like 1.5 to 2, stays there and doesn't go past that mucus barrier. So again, if you have more juice and less barrier, then it's going to start to erode the stomach, the esophagus, or the duodenum. Does that make sense? Okay. And here's another picture that represents that. Your GERD, now Mark asked a question, so is GERD part of peptic ulcer disease or is its own self? It really is kind of its own self because it only is right here in the esophagus. And that's why we've separated the two. Gastric juices are released into the stomach all the time, okay? And if that mucosa, it gets lower or gets to a point where it's not covered, then you start to get an acid. You start to get a sore. Same thing here. If the pyloric valve, the pylorus valve doesn't work right, this acid goes right into the duodenum. And this is going to be the way you're going to tell the difference between, is this a gastric ulcer or is this a duodenal ulcer? Is the onset of pain. And we'll get to that in just a second. There's also a little thing, a little bacterium that was found that if it gets into the stomach, it's the only bacterium that can survive in the stomach because of that acidicness. And it's called Heliobacter pylori, H. pylori. And we're going to get to that because most, 70%, at least 70% of gastric peptic ulcer disease is from this bacteria, okay? And so if that bacteria gets down in here, it just starts to erode it and it gets it bigger and bigger and bigger. We'll get to that in just a second. Questions about these images? It should be pretty straightforward. In fact, most of you are looking like really bored. Okay. This is a really important picture, okay? This gives what are some risk factors for ulcers? What do they lead to? And then there's a little ulcer that is not related necessarily to these common risk factors. Stress ulcers are related to physiological stress, like a traumatic event. So you will see physiological ulcers in trauma patients. You will see physiological ulcers in burns, extensive burns. When the body has gone through a physiologically traumatic event. And this is where they treat these ulcers before they come. They found that this happens when they're intubated in the ICU. They're not even able to talk to tell where there's pain. And all of a sudden, the stomach starts eroding and they start getting GI bleeds. They figured out that this is a stress ulcer, okay? So the common risk factors up here in this corner, he's smoking, there's alcohol, the H. pylori, that bacteria, and stress. Stress is huge to get an ulcer, right? Have you ever heard your parents say, you're going to give me an ulcer? Yeah, okay? Or you gave me an ulcer. True, right? He's waiting for a bus, he's stressed, yeah. His gut hurts, yeah. And those risk factors will then go either give you a gastric ulcer, which is where's the gastric ulcer in? The stomach. And then, or a duodenal ulcer, which is where? Yeah, in the small intestine, in the duodenum, okay? The stress, the physiological stress, the stress ulcers are usually in the stomach. And this can also be from Cushing's syndrome or from a brain injury, from a Curling's ulcer, extensive burns, trauma, shock. Again, the body has experienced a huge traumatic event, okay? So this is where you can study from gastric ulcers, okay? Pain usually happens a half hour to an hour after eating meals, as opposed to a duodenal ulcer, that the pain happens 2 to 3 hours after eating. We'll get to the reason why, and it has to do with that little pyloric sphincter, okay? Eating, for your gastric, eating may increase the pain, whereas in the duodenal ulcers, food makes it better, okay? Those are kind of the differences between the two. So when you have a patient that comes in that says, oh, it just hurts, like 2 to 3 hours after I eat, my gut just hurts. What do you kind of go to? Duodenal, exactly. If they say, oh, it hurts like after I eat, like just like right after I eat, you're thinking gastric. Okay? All right. Questions? These are actual pictures of duodenal ulcers. Where do you think it is? It's the white part. You see how this is a divot? See this? It's eroding, okay? It's not smooth. It's like a sore, okay? It's a gnawing or burning upper abdominal pain that occurs 1 to 3 hours after a meal. That's important to know. The pain is worse when the stomach is empty, and it often disappears after ingesting food. The presence of food, this is the reason why, the presence of food closes off the pyloric sphincter and allows the acid to stay in the stomach. It's not going into the duodenum. It closes off because there's food in it and it has to break it down before it shoves it through into the duodenum. So it makes it feel better because there's not acid on those lesions, which is why 2 to 3 hours later it starts to hurt. Yes? Say it loud so they can hear it.
So you said this slide says 1 to 3 hours after a meal, but the picture before said 2 to 3, and then gastric was half an hour to 1. So like, should 2 be our marker, or is it?
That would be fine. 2 is fine.
Okay.
Yeah. Yeah. It, again, remember, each person's individual in terms of how fast does the peristalsis go through. So it could be as early as 1. It could be as late as 3. 2 is a good middle ground. Okay. Your book says 1 to 3. But 2 is a good middle ground, as opposed to a gastric ulcer that's going to happen, you know, right when they eat. Yeah, right when they eat. Does that make sense? Yeah. Online, if there's a problem, chime in, please. Okay. Here's another. This one even has 2 ulcers. Do you see them?
Yes.
There's one, and look, there's one that's a big one that kind of goes down, and then there's one up here. Okay. I know, it kind of looks like a worm, doesn't it? How do you think they got these pictures? What do you think? Yeah. So again, you have to know what you're treating, right? Have to know what they treat. This is an endoscopy that either goes down to the duodenum, or this is a colonoscopy that goes up to the top of the colon. Okay, so nighttime pain, nausea, and vomiting are uncommon in duodenal ulcers. If the erosion progresses, okay, so like let's say a person comes in and they say, I don't want to be treated. I don't want to do all this medicine. I'll just live with it, okay? Then the erosion doesn't stop. It progresses. It continues to progress until bleeding will occur. And this is where you get into some big time problems, okay? So if you start to bleed in your duodenum, that is what they call a GI bleed. If you start to bleed in your stomach, the stomach does not like blood, and guess what happens? Throws it up and out, and it's bright red, okay? If it's in the duodenum, where do you think it's going to go? It's past the stomach. It's not going to be able to go back in the stomach. Where is it going to go? The other way. It's going to come out. And that's where you get tarry, black, stinky stools. Okay? So when a person says, well, I've been bleeding, you know, I have rectal bleeding, you ask, what kind? Well, if it's bright red blood, that's usually a hemorrhoid. It's usually down near the bottom. If it's like, oh, it's just tarry, it's black, it's like coffee grounds, okay? That means it's higher up and it's gone through and the body can't do with it, and then it gets out, and that's what's left. Okay? Is that helpful at all? Okay. Many ulcers, duodenal ulcers, will heal, but it mostly occurs in people that are 30 to 50 years of age. Look what you have to look forward to, especially going into nursing. It will give you an ulcer. All right, so these are gastric ulcers, okay? So gastric ulcers are where? In the stomach, okay? And these are less common. Most of the time in peptic ulcer disease, ulcer being the key word there, most of the time they're duodenal. Less common is gastric, okay? It's relieved by food. However, pain can continue even after a meal. You get loss of appetite because you don't want to eat because it hurts when you eat. You lose weight because you're not eating enough. And vomiting are more common. Okay? Can you see it right there? Okay, nice and loud.
Weight loss cause gastric ulcers also? I mean, I know you can lose weight because you have let you get one, but
Sure.
a few slides back it said weight loss under gastric ulcers. So could that also cause?
An ulcer?
Yeah.
You bet. You bet. Because remember, it goes back to here you have the mucosa that's protecting the stomach, and here you have the acid. When that gets out of balance and you have more acid and less protection, it's going to start to erode because there's going to be little pits that are going to start to show up because they're Hillen veils. And then the acid's going to hit that because there's no mucus protecting it because you're not eating. Does that make sense? Because you're trying to lose weight. So you're not eating. There's nothing for the acid to work on. So yeah, you can get an ulcer because you're trying to lose weight. And you can also, lose weight when you have it because you don't want to eat because it hurts when you eat. That still never goes away because it's in the stomach. Does that make sense?
Yeah, but like some people that do like the intermittent fasting and stuff for like days at a time, won't you eventually make less stomach acid?
Not unless physiologically your body does that, it would adjust, or you take proton pump inhibitors and antacids and other things to, prohibit or neutralize the acid. Does that make sense? And this is where you get like bariatric surgery. Okay, you get gastric sleeves, and most of the time people have horrific problems with GI motility. They lose the weight because half their stomach's gone, but then they have problems in their bowel and they're at risk for these kinds of ulcers. Not on the test, but bariatric surgery happens all the time. It's like the new weight loss thing. So you will see this in your nursing practice. Okay? Questions? Are we good online? Okay. Gastric ulcers. Okay, severe ulcers may penetrate through the wall of the stomach and cause death because it's called a perforation. That can also happen in the bowel. And these become emergent situations because now you have acid going into the abdominal cavity. Okay, and it's acid. And so it's going to destroy anything that it touches. And this is where your abdomen becomes rigid. This is where you get so sick so fast. And if it's a stomach ulcer, you can die because you bleed out. Okay. So this is more common in those people who are over the age of 60. Some erosions can become cancerous. Okay. If they're not treated, they can turn into cancer. And one of the problems, and we're going to talk about a medication that is a prototype in this book that has been completely recalled because of its association with cancer and these erosions in the stomach. Okay. And medical follow-up continues for several years. Okay. For ulcers. Peptic ulcer disease and GERD is treated by a combination of lifestyle changes and pharmacotherapy. Okay, so you have non-pharmacological plus pharmacological. They work together. Remember, rule of thumb, you always go non-pharmacological first. If that doesn't take care of it, you add the pharmacology to get the treatment. GERD, we're going to find out here in just a little bit. GERD is a chronic condition. Once you have it, it's the rest of your life. Okay. Peptic ulcer disease can, it kind of comes and goes. So you have good times and bad times. All right. So let's talk about lifestyle factors that you need to be aware of. And so obviously the opposite of this is what you're going to want to do. Okay. So if you have stress, I know nursing school, the opposite of that is don't be a nurse, right? Or get rid of other stresses in your life, okay? Or learn how to deal with them. Do some guided meditation, okay? Obesity, huge in peptic ulcer disease and GERD. Caffeine. You guys love your monsters, right? Okay. Caffeine affects that balance of acid and mucosal. Alcohol, smoking, use of drugs, such as corticosteroids and NSAIDs. Okay, NSAIDs is your ibuprofen. Somebody comes in to the doctor's office and they're like, oh, I have this gnawing pain, and he has osteoarthritis. What do you think he's going to be taking for his osteoarthritis? NSAIDs. Guess what now that he has or she has? Yeah, peptic ulcer disease. Yeah. And possibly even an ulcer, either in the stomach or in the duodenum. Okay. Do you see how those connect? This is when you go, yes. Okay. So somebody that's on steroids, prednisone, what are they at risk for? Ulcers, yeah. And infections, right? Because they're immunocompromised. Good job. Okay. All right. So these are non-pharmacologic measures for GERD as well as for peptic ulcer disease. Avoid alcohol and tobacco. We just talked about that. Lose weight. Okay. The pressure that happens as it pushes up on the stomach is where it happens. Hot, spicy, greasy foods. No bueno. Don't take them. That includes acidic things like tomatoes. How many of you can't do spaghetti because it just gives you heartburn? I have a son that happens to. He can't do tomatoes in any way, shape, or form. Gives him heartburn. He also, as an infant, had pyloric stenosis. Okay, you guys went over that in the last couple of days, right? Especially for pediatrics, where that pyloric is so tight that nothing can kind of get through and everything comes throwing up. This kid's been throwing up since he was, 3 weeks old. Raise the head of the bed. Why do you think that would be a good idea for GERD, to raise the head of the bed when you're sleeping? Okay, because where is GERD located at? In the esophagus, right? It's the gastric acid coming into the esophagus. So if you raise the level of the bed a little bit, is it going to have as easily of a time as if you're laying down? No, it's going to be harder. So that helps decrease it. And wear loose-fitting clothing. If you wear tight-fitting clothing, everything gets pushed up, and that pushes the acid into the esophagus. Pretty straightforward, yeah? No? Okay. So, any questions? All right. So these are risk factors for peptic ulcer disease. And this is the primary reason people get peptic ulcer disease of ulcers. Now remember, ulcers is an actual sore, either in the stomach or the duodenum. Okay? It is by the bacterium Helicobacter pylori, H. pylori. It can cause gastritis and it can cause ulcers. And the way that we found this out is this scientist said and presented evidence that said, this is what's happening. And the entire scientific community said, oh, you're full of it. So what did he do? He swallowed a thing full of H. pylori, swallowed it, gave himself a peptic ulcer, and then did some treatments, the antibiotics, that showed it went away. And then everyone was like, in the scientific community was like, oh my gosh. And then that spawned huge amounts of research and found that the most common cause is this bacterium called H. pylori. Now it's a bacterium. It's not a virus. It's not a protozoan. It's a bacteria. That's important to know. In non-infected patients, okay, so people that don't have H. pylori, the most common cause is because they take NSAIDs or long-term corticosteroids. That's where they get peptic ulcer. All right, so here it is. Here's a question for you. Chime in the chat. Is peptic ulcer disease considered an infection, an inflammation, or both? And why? Okay, we hear some boths here. What about in the chat? What are they saying in the chat? Okay, and why? I would agree with you. Why is it both? Okay.
Can cause infection, and inflammation is caused from the gastric acid.
Okay, I would agree with that. I would agree. Did you hear that online, or did online chime in too? You always have inflammation before you have infection. You always have inflammation before you have infection. Yeah. And once you have infection, are you still going to have inflammation? Yeah, it's still going to be red. Still going to be an issue. Okay. All righty. Let's go through a little bit and then we'll stop at 12. Is that okay? We'll stop at 12. Okay. So this is a hugely important picture and it's on page 624. So on the side, you see where it says vagus nerve. This is how these chemicals are released that produce hydrochloric acid and that produce pepsin. So remember we talked about it's out of balance. There's too much of the acid and not enough of the protection. And so the really smart people that develop drugs, they focus on different kinds of receptors. So these classifications, the tranquilizers, the anticholinergic, the histamine 2 blockers, proton pump inhibitors, antacids, prostaglandins, and pepsin inhibitor, those are the classifications of drugs that are used to treat peptic ulcer disease and GERD. The only ones we're going to focus on, because those are the most common, those are the ones that as LPNs you're going to see, is what is highlighted with the arrows. Okay, so the histamine 2 blockers, the proton pump inhibitors, they're also known as PPIs, the antacids, the prostaglandin, we're going to go over it, but it's not, there's one question on the test about it. And basically it's a contraindication. And a pepsin inhibitor. If you block pepsin, this medication we're going to talk about actually helps build mucosa. It's like a Band-Aid. It helps protect the lesions, those little divots that you saw in those pictures. Okay, so does that make sense? Where we're going to focus on. Okay, I tried to put this in the PowerPoint. I know it sounds like, yes, this is just dumbing it up. I try to make it simple so that you can go back and you can see what you need. Okay, and what you need to know as a nurse. All right. So let's talk about GERD a little bit. Mark was like, okay, is this part of peptic ulcer? It's a little bit different. Again, it's just in the esophagus. It's a chronic condition, okay? It doesn't go away. You can continue to treat it so that it doesn't hurt, but it doesn't ever go away, okay? It has times where it gets better and bad. Common conditions it's a common condition which, again, the acid moves upward towards the esophagus. It causes intense burning. It's known as heartburn and may lead to ulcers in the esophagus. Now, here's a question. A couple of weeks ago, we talked about a cardiac unit, and we talked about how women present with chest pain. And do you remember how they present with chest pain? Heartburn, indigestion. So, okay, is this heartburn? Is this indigestion? Is it chest pain? Okay, it's the reason why it's the #1 killer for women, because it's like, oh, it's just heartburn. I still got to go do laundry. I got to run the kids here. I got to do this. I got to show up for work here. Okay, we never listen to ourselves. But the guys, it's usually there's pain, up the neck, down the arm, but still they can experience heartburn. So be aware of that one. No, there's not a question on the test about the difference between indigestion and chest pain, okay? But you will see this when your patient says, I have chest pain. Okay, where is it? What does it feel like? That's where the caldera comes in. All right. It can include ulcers in the esophagus. All right, so this is a picture of what it looks like. The acid goes through the cardiac sphincter up into the esophagus. It's strongly associated with obesity. That is an important thing. There is a question on that. Losing weight a lot of times eliminates the symptoms. Many drugs that are prescribed for peptic ulcer disease are also used to treat GERD. Okay, that's the reason why it's kind of included here. Symptoms include, here's your symptoms: heartburn, dysphagia, dyspepsia, chest pain, nausea, and belching. Okay, if you've ever had, does anybody get heartburn here? Anybody have families that get heartburn? Okay, way in the back, how do they describe it? What happens when they get heartburn? And nice and loud. Okay, he said it burns. Does he grab anything? Does he grab here? Does he grab here? It's your father-in-law. You just know he has heartburn. Okay, anybody online that has it? That chime in? Again, remember it's mid-age. I guarantee you'll get heartburn from being a nurse. Okay, symptoms worsen after large meals, after they exercise, and when in a reclined position, when they're laying flat. We kind of talked about that, why that would happen, right? That acid's easy, it just goes right up. Same thing for kids, guys, okay? For babies, if you have babies that, that are screaming when you lay them down after they're eating, put them up a little bit and see if that helps, okay? Their little sphincters are still immature, okay? All right, this is treatment, okay? So this is how we treat it. We treat GERD with an H2 histamine 2 blocker, such as Pepcid, okay? We also treat it with a proton pump inhibitor, like omeprazole, which is also known as Prilosec, or lansoprazole, okay? They're better than H2 blockers. They, and we'll get into how these drugs work in just a second. We treat them with antacids, and sometimes you actually have to dilate the esophagus because things get so shrunk down and scarred down from that acid that nothing goes down. And then food gets blocked, and then they have to get their esophagus dilated. Have you ever had a patient that's like, oh, I've got to go get my esophagus dilated? That's the reason why. They have GERD, okay? It's a chronic disorder, and continuous. Okay, hear it again. Here's non-pharmacological. Raise the head of the bed. Don't eat before bedtime and wear loose-fitting clothing. So the picture that's over on the right-hand side is antacids, H2 blockers, and PPIs. So in GI disorders, especially with peptic ulcer disease, you will see combinations of these drugs that are used to hit the parietal cells, the chief cells, neutralizing the acid that's in there, and some other medications that cover and help protect the lesion that might be there, okay? So definitely understand GI, you're using multiple drugs to address the issue. Okay? All righty, let's try this again. We'll just go it together because it's not working. So here's the PUL-EV. A patient's diagnosed with peptic ulcer disease. The nurse realizes that which of these is a predisposing factor for this condition. Write it in the chat so that I can see that you've responded, whatever you think it is, and then we'll go over it. Okay, A, B, hyposecretion, C, decreased hydrochloric acid, D, E. coli. A is H. pylori. Which one do you think it is? A. And I tell you how important this is. Okay, again, these are questions that came directly from the end of the chapter in your book. Okay, alrighty. So let's talk about H. pylori. Okay, it's gram negative. What does that tell you? You just had a whole big antibiotic thing. What's a gram negative? Yeah. It doesn't have the extramembrane wall, and yet it's amazing because it survives in the hostile condition, hydrochloric acid, and it survives. It's a bad juju, dude. Okay, 70% of patients with peptic ulcer disease have this infection, all right? Research has shown that the eradication of this decreases the recurrence of peptic ulcer disease. If you can get rid of the bacteria, then they don't have it anymore. So teaching, when you're talking about medications, what do you think is going to be in part of the medications to treat H. pylori? Antibiotics, yeah. So not only are they doing antacids and proton pump inhibitors and things like that to reduce the gastric acid, but they're killing the bacteria through antibiotics. So you're going to add antibiotics in there, okay? So here's the risk factors for getting that, okay? If you're in a developing country, or if there's domestic crowding, unclean water, huge of where it lives. And then you drink the water, boom, you have it. Okay. Exposure to gastric contents of an infected individual. This is why you need PPE if somebody is puking. Okay. Or be downwind. Okay. You don't want to get splattered. Had a trauma surgeon splatter me one time. He was putting in a chest tube and I'm like, wait, because they clamp it. He didn't wait. And it just exploded. Thank goodness I had my PPE on. But what was behind me was a silhouette of me. The blood went around the side of me, on me, and I looked around and there I was. Yeah, and I was just covered. So if somebody's starting to puke, make sure you have PPE on, okay? Not on the test. You really need to know that, okay? All righty. It's the only known microbe that can survive in the stomach. Everything else doesn't do it. Okay, so here's regimens or treatment regimens that are used to eradicate H. pylori. We know that it's gram-negative, but it's a combination of drugs, usually 2 antibiotics and 1 proton pump inhibitor. Sometimes they'll use 2 antibiotics with bismuth, that's an antacid, we'll get to that in just a second, or an H2 blocker. Okay, but again, the most important thing, even though we know 70% has an H. pylori infection, when they come in, do you just automatically give them an antibiotic? No, you have to know what you treat. And there are questions on that on the test. You have to know what you're treating. There has to be a diagnosis. And the interesting thing, there's 3 ways that you can be diagnosed from H. pylori. In the breath, they have you drink a solution that if you have H. pylori, the bacterium, it causes a chemical reaction, and then you blow into like a breathalyzer, and they can measure that, and if that substance that they're testing for is there, you have it, they prescribe it. The other one is blood. They're looking for antibodies because your body is trying to fight this. And if you have antibodies for H. pylori, you have H. pylori. Okay, it's trying to fight it. The other one is stool. They'll look for H. pylori in the stool. Okay, all right. So these are antibiotics that are used to treat Helicobacter pylori. And so, you know, wow, that's a really great test question. The nurse knows that to treat this, which medications would the nurse use or expect to be ordered in someone with H. pylori? Amoxicillin. Amoxicillin is broad spectrum or narrow spectrum? Thank you. Clarithromycin, okay, and Flagyl and tetracycline. Most of the time they will do, they've started to add Flagyl. They started just routinely to go to Flagyl and like amoxicillin, okay? Or the clarithromycin, because amoxicillin gets kind of resistant, okay? So this is where you add proton pump inhibitors, H2 receptor blockers, antacids, antibiotics. That's the 4 combinations. And miscellaneous drugs. What's usually the miscellaneous drug for GI? There's only one.
It's the hang on.
Yeah. And it's also known as, starts with an R, Reglan. Okay, so when you're dealing with H. pylori, you're being hit with everything. Everything that happens in the GI plus antibiotics. Okay, we're going to stop here because now we're going to start going into the drugs. Everything that's on your unit, I have divided into which categories they are. Isn't that nice? And so that way you can see which classification and what those drugs are and what they do. So like I said, it's straightforward, guys. Okay, so we're going to take a break. We'll go through in what, 25 minutes? Is that good? How long do you need? 40 minutes? How about 30? 30 minutes. Okay. All right. We'll start back at 12:30. Oops, sorry. Okay, we're back at 12:30 here. Let me get our little thing back up. Okay. All righty. Go ahead and eat. We understand. Just kind of clean up around. Try and bring up. I wanted to clarify a couple of things. We talked about, and this is important, because remember when I say it's important, this is a test thing. So I want.
Debbie?
Yes.
For some reason, Debbie, sorry, I'm on here. I don't know if it's just my computer, but I can't hear you, even though you're unmuted.
Let me check. Hang on.
I can hear her.
Can anyone else hear me online? Chime in
Yeah,
here.
I can hear you.
Okay. So who was it that can't hear me? Stephanie? Oh, she's going to restart. Okay. Because it says that I'm sharing. It says, and it looks like everybody else can kind of hear. Okay. So I just want to clarify a couple of things that's going to affect you on the test. We've talked about medications that work well for chemo, and we've talked about medications that work well in like PACU, okay? So do you remember PACU? What medication worked well for PACU after surgical procedures to address nausea and vomiting? Steroids, yeah, steroids. When you're talking about chemotherapy and preventing it in chemotherapy, the best one is Zofran. You see the difference? Chemotherapy versus surgical procedures. Oh, stop.
I guess earlier.
Yeah, and that's why I wanted to clarify. Yeah, this is the reason why I'm clarifying is for nausea and vomiting, for surgical procedures, the best one that's the long term is steroids, like what Mark said. You rocked it. But if you're talking about prevention of nausea and vomiting in chemo, Zofran. Because remember, Zofran is used in chemo. Okay. So I wanted to clarify that one. Also, if a person decides that they don't want to treat their ulcer, what's going to continue to happen? Okay, so it's going to continue to erode. Good job. What else? Perforate, right? So that can be a perforation of the gastric or the intestinal lining. And then there was one other thing that was associated with that. The erosion, the perforation, before it perforates, usually there is bleeding. Yeah, okay? So make sure you understand if people don't want to treat this, this is the lane that they choose, okay? All right. Okay, let's move on. Let me get back to where I was at. Okay, so we're talking about antacids, okay? So antacids rapidly neutralize stomach acid and they reduce the symptoms of peptic ulcer disease and GERD. These are the three that are on your list that are in your unit, okay? Aluminum hydroxide, calcium carbonate, those are known as TUMS. And there's a whole table on page 626, 43.4. The two that you really need to know about is what I've listed here, okay? But they all work in the same way in terms of they neutralize the acid. And this is important because the difference between an antacid and one that's like a proton pump inhibitor or an H2 blocker, those reduce the amount of acid going into the stomach. An antacid does not do that. It simply neutralizes what's there. It raises the pH and it neutralizes so it doesn't hurt, so you don't have that acid in there. Okay? That's the reason why if you take an antacid, you take an enteric-coated medication, it may inactivate the enteric-coated. It starts to break it down, and instead of that medicine going through the stomach and breaking down in the small intestine. Does that make sense? Was someone chiming in online? I'm sorry. Okay, testing the mic. Who was it that couldn't hear me? Can you hear me now? Can you hear me now? Are we good? Can you check the chat? Okay, all right. So that's a huge difference. All right, I put this in to hopefully make you laugh as you do your medication brochure. Okay. All right, I know that lasagna gives you heartburn, so I mix some Tums into it. I know. Now everybody's sick because now you're... All right, so here's pharmacotherapy with antacids, okay? They're alkaline, right? Alkaline neutralizes acid. That's the reason why they're alkaline. They neutralize the stomach acid. They provide temporary relief from heartburn or indigestion, but they're no longer recommended as the primary drug class for acid-related disorders, peptic ulcer disease. That they're no longer the first line of drugs, okay? They're used to kind of augment. Everything in GI has combinations, okay? We just talked about combinations. That's going to be a test question on your H. pylori, you know. What medications would you identify that you would treat with H. pylori? We talked about antibiotics. We talked about specifically which ones. We talked about a proton pump and an antacid. Okay, they only relieve symptoms of heartburn, but they don't promote ulcer healing. Okay, and they do not help eliminate H. pylori. H. pylori is eliminated by antibiotics and then kind of protecting and reducing what has already gone on from that disease. Okay, they usually are contained aluminum, magnesium, sodium, or calcium. And each of those kind of have good and bad. And there's going to be a slide here, just a second, that gives you the good and the bad and the ugly as to which ones do what. And a lot of times they will combine the good and the bad together, so it kind of neutralizes their adverse effects out, and then they put it out as one. And even in pharma, what they're doing now is they're taking an antacid and they're now latching it on to a proton pump inhibitor. So you only take one pill that covers two different things, okay? They don't protect the stomach by coating the stomach wall. To be considered therapeutic, the dose of antacid should increase the gastric pH to a minimum of 3.5. That's when it stops hurting. It's 3.5. They act within 10 to 15 minutes. They are quick, okay? But their effects only last 2 hours. That's important to know because there's some great test questions about, you know, this person has this condition. When would an antacid be appropriate? Or is an antacid appropriate? Or what medication would you choose? Okay, you need to know how fast they come on and how much they last. Okay, all right. So again, they're inorganic compounds of aluminum, magnesium, or calcium. And again, they have combinations of aluminum hydroxide and magnesium hydroxide are the most common types. And that's where you will see in your Rolaids, things like that. You can look on the side and they'll say, you know, aluminum hydroxide and magnesium hydroxide. Okay, so we talked about a combination of products that combine antacids, H2 receptors into a single tablet. I just talked about that. Simethicone is used a lot in babies, okay? It's an anti-flatulent, so it gets rid of gas, and it's sometimes added to the antacid preparation, so it reduces gas bubbles that cause bloating and discomfort, okay? And so Gas X is simethicone. So if you've got a baby or if you've got an adult that, you know, has gas, they will prescribe these, you know, they'll tell you, go get these. These are all over the counter, okay? So here is the wonderful little chart that you need to know about, okay? They're equally effective. It doesn't matter whether you're talking about a sodium, magnesium, calcium, aluminum. They all are effective in neutralizing the acid that's already in there. It doesn't decrease the amount of acid that goes into the stomach. It just neutralizes the volume. Okay, you got to know that one. Each type has disadvantages. So look at this. Let's look at magnesium, all right? So it can cause symptoms of hypermagnesia, but magnesium acts as a laxative, okay? So great, you take care of your, your heartburn for a few minutes, but holy smoke, it gives you diarrhea, okay? But look at calcium. Calcium causes constipation, okay? So does aluminum. So would it make sense to mix a magnesium with a calcium? Yeah, because it kind of cancels out the issue with diarrhea, right? And they're both antacids, and they both help neutralize the neutralize it. So just be familiar with this, especially their disadvantages. Okay. And bicarbonate. So bicarbonate, sodium bicarb, okay, is an alkaline, but bicarbonate actually goes systemically. So if you have a patient that's already at risk for alkaline acid alkalosis, you want to put a bicarbonate with them? No. Yeah, because that's going to even make them more alkaline. So people that are at risk for metabolic alkalosis, you don't use bicarb. All right. Questions? Okay. So there's multiple drug interactions with antacids that occur with several mechanisms. Is that someone? Oh, the water bottle. Okay, sorry. We talked about enteric-coated or delayed release. They're designed to dissolve when they reach an alkaline environment in the small intestine. So if you raise the pH in the stomach, then a lot of these enteric-coated drugs, they get fooled and they start to dissolve. So what do you think would be appropriate if you're to give something that's enteric-coated and they're having heartburn? Would you give this at the same time? So what would you give first? No, that was what, not why or how. What would you give first? It's just a question. What would you give first, the antacid or the enteric-coated?
I mean, the antacid, because you don't want to dissolve, leave it as enteric-coated, it can still alter it, can't it?
Okay, so you want to, if you give the antacid first, how long do you think you should wait? Yeah, 30 minutes. 30 minutes before you give an enteric-coated. Yeah. Okay. All righty, so let's go on. Oh, is that okay? They're just doing things back there. Okay. I know. So remember we talked about it can alter the absorption of the drugs. That's the point here. When urine is made more alkaline, it can increase or decrease the excretion of certain drugs. So this is all about antacids. Because these drugs are available over the counter for self-treatment, nurses, for education, you must emphasize taking the drugs as directed. As directed. People think, oh, I can take this every hour. I can take this every half hour. Okay. Because it's like, oh, I just have heartburn. I'm just going to keep taking it. And they can get into a lot of trouble in terms of your body because that's not fixing what the matter is. Okay. All right. In order to avoid drug-to-drug interactions, medication should be taken 1 hour before. Here's the answer to the question. 1 hour before or 2 hours after giving an antacid. To make sure that antacid is out of the system, out of the stomach. Remember, it has a really quick onset of action, but it gets out of the system quick. Gets out of the stomach quick. Okay? All righty. So here's the question. If you're online, put your answers in so I can make sure that I see them. Here we're gonna just stay out your question. When a patient complains of pain accompanying a peptic ulcer, why should the nurse give an antacid? Okay. A, B, C, or D? What do you think? I know there's some dazzling distractors, isn't there? This came right from the back of your book. All right, A, how many agree with A in here? Okay, how many agree with B? Okay, how many agree with C? And how many agree with D? Okay, all right. Yes, they neutralize the hydrochloric acid. They don't decrease it. They don't increase or strengthen the esophageal sphincter's action. They simply neutralize the acid that's there. Okay, good job. All right, so now we have histamine blockers. If you remember back on that page, as we go down, it's released, the acetylcholine releases histamine, and histamine is needed to make gastric acid. So we're blocking the release of histamine. Now, histamine is something that you go, wait a minute, I've heard of histamine. Histamine 1, right? That was a few weeks ago. What was that related to? Histamine 1. Yeah, allergies, allergic reaction. This is completely different. That acts on the H1 receptor throughout the body. This acts on the H2, the histamine 2 receptor in the parietal cells, strictly in the parietal and chief cells. That's all histamine 2 acts upon, okay? And it blocks that so it can't continue to then make hydrochloric acid. Does that make sense? That's why they say this is an H2 blocker. Okay, these are phenomenal drugs. And this is what's replaced the antacids because they're so much better in reducing acid that goes into the stomach. Okay, so there's a few of them. I've listed them here. Now, this ranitidine, Zantac, and here's your last names. Most of the H2 blockers have dine or dine on the end, D-I-N-E. Most of them will have that. Okay, so the cimetidine is Tagamet. That's been around since the mid-70s, guys. But it has so many drug interactions that they created newer ones. And then they created Zantac. Zantac was phenomenal, and everybody took it. Then they created Pepcid, which was more potent than Zantac. And then shiz hit the fan when all of a sudden people started having cancer. And they started doing research, and they realized that in Zantac there was a compound, an inactive ingredient that all of a sudden became active and gave people cancer. So as of this year, the FDA has pulled it. There is nothing on the market on that, and there are huge lawsuits. People that are suing Zantac because they got cancer from this when it was supposed to be protective. Okay, it was supposed to reduce the acid. Okay, so the most important thing in your book, this is where it changes because in your book it has a prototype, and the prototype is what? Guess what? Zantac. Okay, but famotidine, the Pepcid, that's the one we're dealing with. That's the one you will deal with. Nobody's taking Zantac anymore. Okay, and except your dad. Yeah. Get it off his shelf. Replace it with Pepcid. All righty. Okay, so let's talk a little bit about the histamine. We've talked about it. H2, the histamine 2, is on the parietal cells in the stomach, and they promote gastric secretion when they're activated. So they're blocking that. They're not letting that go down that path to create acid, okay? The H2 receptor antagonists effectively reduce both fasting and food stimulated secretion, and they decrease nocturnal acid secretion. Okay, that's important to know. So when someone says, I just really, I have heartburn and they're at night, what would be a better drug, an antacid or an H2 blocker? Yeah, exactly. I think that's a really good test question. So these drugs are rapidly absorbed and it occurs in the small intestine, which isn't affected by food. So can you give this with food? Yeah, it's not an antacid. Antacids are what you have to be worried about and medications. Does that make sense? Because it raises the pH. All right. These drugs can cross the placenta and are excreted in breast milk. Okay. So you do need to be aware of that one. Okay. All righty. They're responsible for, it's decreasing. Sorry, that's not increasing. That's a typo. Cross it off. It's decreasing acid secretion, the blocker. The H2 receptor, okay, the actual receptor is responsible for increasing the acid. The H2 receptor blocker, we're blocking that, decreases the secretion. Does that make sense? So the whole purpose of H2, the H2 receptor in the parietal cell, is to make acid. That's its whole purpose. This H2 receptor blocker blocks it from doing that. Does that make sense? Okay. And they're widely used for peptic ulcer disease and GERD to promote healing and prevent recurrence. Because if you don't have as much acid going into the stomach, then that balance comes back in, or it even may even be a little bit better. You know, it has a little bit more protective barriers than the acid. Okay. And so antacids do not promote healing. H2 receptor blockers do. Does that make sense? Yeah. Okay. Everyone's like, yeah, will you just hurry up? Pepcid and other drugs suppress the volume and the acidity of the stomach acid. Okay. Available and over the counter and for short-term use for treatment with heartburn. Okay, so antacids neutralize it right then. H2 blockers are short-term to reduce the amount of acid. Okay, and that's why it helps with GERD. Okay, adverse effects are minor. Yay. Have you ever had a medication that didn't have a long list of adverse reactions? Does this make you a happy person? This should. Okay, patients should be advised not to take antacids at the same time as the H2 receptor blocker because the absorption will be lessened, okay? Because these drug H2 receptor blockers are supposed to be activated not in the stomach, in the duodenum, outside of it. And if you have antacids, it messes up the absorption. Okay, so here is your Pepcid prototype. The class, the mechanism of action, we've talked about that. They do have, the adverse effects are rare, but you can get a headache, dizziness, and constipation, okay? Contraindications, if you're allergic to it, okay? It's not suitable for children, and it's used with caution with patients with renal impairment or liver disease, okay? That sounds like a really good test question. The contraindications. Contraindications. When would you not, caution for renal and hepatic? Okay. Drug interactions, we talked about that. Antacids, it decreases it. And nursing responsibilities, okay? Obviously, you're assessing and evaluating GI complaints because things can get worse, right? If they're in the hospital, if they're in acute care, if they're coming back in a clinic situation, and things can get worse. So you're always asking them, is your pain better? Does your stomach hurt? Let me palpate things, okay? And checking for abdominal pain and blood in the stool. Because just like what Kenna said, you can perforate it, okay? You're going to perforate, you're going to have blood in the stool. Okay. All right, let's move on. Questions? Okay. So drugs similar to Pepcid is Tagamet. We've talked about it. There are numerous drug-to-drug interactions, and it has to be taken 4 times a day. This is the reason why it's not used hardly at all anymore. It can cross the blood-brain barrier, so it causes CNS depression and confusion. Zantac, again, we talked about. It's almost identical to Pepcid. It's less potent, and the FDA pulled it. So you will not have any questions about Zantac. But I can guarantee you will have questions about Pepcid, okay? Because that's what we've replaced it with. Okay? Questions? All right, let's see how well you're awake. All right, online, can you chime in here? We'll raise hands. All right, a patient is taking famotidine, which is also known as Pepcid, which is a H2 receptor blocker. What information should the nurse teach this patient about this drug?
For sure.
Okay, look at A, B, C, D, E, F. All right, what do you think? Hang on. Okay. All righty. A, how many think A? In here. Okay, that is correct. It is. It's wrong. Does that make sense? Like you chose correct.
Okay.
That's what I was saying. Sorry, you chose correct. What about B?
I don't think that's an answer.
What about B? That's a dazzling distractor.
I don't think it's an answer.
Yeah, it doesn't, because it doesn't interact with food. Doesn't interact with food. What about C?
Yes.
C is definitely one. Yeah, we talked about it. It has to be administered separately from an antacid. What about D? Must always be administered with magnesium hydroxide. What is magnesium hydroxide? An antacid. Okay, yeah, so that's a no, right? You just answered it up above. You said, yes, it has to be administered separately. So D is going to be, no, that's not true. What about E?
Sure. Always good answer. Smoking, stop it.
You bet. You bet. Yeah, nicotine actually increases gastric acid. What about F?
Sure.
Foods high in vitamin B12 should be increased in the diet. Yes. Vitamin B12 helps with absorption. So this is, and that answer you will find as you look more into Pepcid. You'll see that B12 interacts with it and helps absorption. Okay. All right. Questions? Okay. Here's another one. A patient is taking famotidine to inhibit gastric secretions. Which side effect of famotidine does the nurse teach the patient? This is a select all that apply. Sorry. I know. You're like, what? I'm sorry. Select all that apply. Is the chat chiming in, guys? Can you look just quick? Are they chiming in? Okay. Are they done, or are they still kind of? Are we done? You guys need more time? We're good. Okay. What about A? Yes, that's true. That was on the chart. A, dizziness. Yes. B. Sure sounds great, or I'm sure? I'm sure. That's right. B is correct. Okay, that's on the list. If you go back a couple of slides, you'll see they're rare, but they do happen. Okay, so headache and dizziness do happen. What about hypokalemia or hyperkalemia? No. What about blurred vision? That's a no. That's a no. It doesn't, I know, it's a dazzling. It's a dazzling. Okay. So H, so here's your key. Okay. If you see a test question that has which side effects and you have blurred vision, is that a side effect of an H2 receptor blocker? No.
Maybe it's an adverse effect. I don't know.
It's a no. What about F? It can affect erectile dysfunction. It's not irreversible, but it can affect it.
Ulcers are erectile dysfunction.
I know. Do I want my stomach to feel better, or do I want to be able to pleasure my partner? Yeah. Hence the reason why people don't take care, they don't address their problems with their tummy. All right. Proton pump inhibitors, also known as PPI, they are also effective in reducing gastric secretion. And these also have a last name. What's the last name? Zoll. Zoll. Okay. And so again, they're similar to an H2 receptor blocker. Okay. But they don't affect the parietal cell. They affect the proton pump. The proton pump is what squirts it out, squirts the acid out. Okay? So they block that. And so they're a little more potent than an H2 blocker, H2 receptor blocker. And that's the reason why a lot of times they're used in combination to do that. Okay? And these are the ones that are on your list of medications to know. Okay? And there are some little caveats to some of these that we're going to get to in just a moment. I will tell you Protonix. Remember how we talked about stress ulcers that happens when the body has experienced a traumatic event and it just kicks up the secretion of the acid? Protonix is used for that, for stress ulcers. Clicked on Protonix, that's right. The other one we're going to get to, Prevacid, and there's a test question on this one. Prevacid is the only one that comes in a oral solution, a liquid solution. Yeah. Okay. So that's important to know. Prilosec is one of the most common ones that are used. People that are needed, and then Nexium. Nexium's known as the purple pill. That was their advertising. Okay. All righty. So let's look at that. They act by blocking the enzyme responsible for secreting the hydrochloric acid in the stomach. It's one more level down than where the H2 receptor is on that picture that was a few slides ago with the arrows that we were going to focus on. Okay, they are the most effective medications available for reducing acid secretion and are thus the preferred drugs for the treatment of peptic ulcer disease and GERD. So if somebody goes in and they have that, that's the first thing that the physicians will prescribe is a proton pump inhibitor. Then if that doesn't get it fixed, they will add a H2 blocker and a antacid. And then they'll add Carafate, which we'll get to in just a second. That's when they're doing endoscopies. They're looking to see if there's an ulcer. That's when things get excited. Okay. So they reduce the acid secretion by binding irreversibly to the enzyme hydrogen potassium ATPase. The most important thing to know is the irreversibly, okay? Because they once they bind to that, it's irreversible. So the nice thing is that you can miss a dose and still have protection, because the next time you take that dose is when the receptors are recycling, the cells are recycling themselves. Does that make sense? So if you have a person who's NPO, okay, and they come running to you and say, I have to take my Nexium, I have to take my omeprazole, but because they're having surgery the next day, it's okay. If they had it that day before they had to be NPO, it's fine. It's fine because they have a long half-life. They bind to that proton pump, and that proton pump is basically killed until another proton pump comes in and replaces it. Irreversible. Quote, yeah.
You have a new pump that comes into play.
Yeah. And when you have a new pump that comes into play, then that's why you take it on a regular basis. But they can miss a dose. And I believe there's a test question on that. All right. And just for your fun and games, I put the purple pill. What's the purple pill? Nexium. Okay. All right. They're usually continued for 1 to 2 weeks. In refractory cases, that means that they're not responding. Therapy can continue for 4 to 8 weeks. Because when you get to ulcers, it takes 1 to 2 months to heal an ulcer. I believe there's a test question on that. Its beneficial effects last 3 to 5 days. That's where I was saying if they miss a dose, it's okay, because it usually takes 3 to 5 days to get a new proton pump cell. Okay, and they're still beneficial after therapy stop for 3 to 5 days. Okay, all right. So there's omeprazole. Its mechanism of action, adverse effects, contraindication, drug interactions, and nursing responsibilities. Make sure you're familiar with those, especially with Plavix, okay, the drug interactions. And let's see, that's about it. That's about it. It does have an increased risk of C. diff in diarrhea in hospitalized patients, but I don't think there's a question on that one. Okay. Similar to omeprazole, which is the prototype drug, Nexium, Prevacid, Protonix, okay? Nexium can be squashed, okay? So you can open the capsules and you can put it into applesauce or whatever. Remember, we said capsules you don't crush. Nexium you can. Only one, but you can. And then the Prevacid is the one that I said was available in an oral liquid solution. I believe there's some sort of a question on that, about that. And Protonix is used for stress ulcers, and they use it prophylactically. So if you're a trauma patient and you're admitted into the hospital, one of the standard orders is Protonix routinely to reduce the chance of you getting a stress ulcer. Burn patients, same thing. Okay, here we are. All right, online and in class, patients taking omeprazole, magnesium for erosive GERD. Which should the nurse include in patient teaching? A, B, C, or D? What do you think? Yeah, erosive means that there's a sore. It can take upwards of 1 to 2 months. Okay, online, are they chiming in? They all said C. All right, let's take A. Take the medication daily with breakfast. Yeah, doesn't affect it. You can take it or you don't take it. Doesn't matter. Healing should occur in 1 week. Why is that not correct? Yeah, it takes, yeah, it's usually 1 week is like the minimum before you're going to start to see any kind of difference. C, this medication decreases stomach acid secretion. Is that true? Yeah. You bet. That's the right one. A blood test to check kidney function should be done. No, that's back with your like H2 blockers. Check with the renal. Okay. All righty. So there it is. All right. So now we're going to talk a little bit down farther, which is called a pepsin inhibitor. And this is where it actually creates a protective barrier for the mucus, okay? And it's called Carafate. And it uses sugar plus aluminum hydroxide, which is an antacid. They combine them together. When it hits the gastric acid, it has a chemical reaction that produces a thick gel-like substance. And it is drawn to where the pits are, okay? Where these little things are right here, these little pits. It's drawn to it and it fills it in and it protects it. So it's like a Band-Aid for an ulcer, okay? And it does not, so that it doesn't allow the sore, the erosion to get bigger, and it promotes healing. It's like a Band-Aid. And it does not affect the secretion of acid. Okay, it's a protective barrier. That's the key word there. And there are questions on the test about Carafate. What does it do? Okay, it mixes and causes protection over the ulcer. Okay, this last one is a prostaglandin anti-ulcer drug, and it is called Cytotec. Anyone work OB?
Yes.
Okay, do you, are you familiar with Cytotec and OB? What does it do? Nice and loud.
It's used for either in a hemorrhage or it's used to help the cervix become soft.
You bet. And it's used in anything else that you wanted to add? Okay, yeah. Okay, all right. So you work postpartum. So we said it was used as because of a hemorrhage or to soften the cervix, okay? So if a person's getting induced or maybe they've had, there's no longer fetal movement, they have to deliver this baby, it's 5 months old, whatever, they've got to get it out. They will put a suppository in the cervix and it softens it. And if they're using it in hemorrhage, it's contracting the uterus. So that's what it does. It's also, believe it or not, that's an off-label brand. That's what they use off-label. It was created for a GI. So what do you think the black box warning is going to be? Yeah, pregnancy. Don't use it in pregnancy because they still use this to also cause medical abortions, okay? Because it causes the uterus to contract. And yeah, it does work as an anti-ulcer drug, but here's the problem. If the patient's pregnant, you stand to lose the pregnancy because of also what it does. So you just need to know that Cytotec, you don't use it in pregnancy. That's the connect, the wink, wink, okay? All right, there's also miscellaneous drugs, which is Reglan, okay? And it's used to treat nausea and vomiting, but it's also used as short-term therapy because it affects the motility of the bowel. It's also the reason why they use it in surgery, okay? It's available in oral, IM, or IV. Good drug. All right. Here it is. Student nurse is preparing, that'd be you, is preparing to administer sucralfate, also known as Carafate. Which statement by the student nurse demonstrates understanding of sucralfate's mode of action or mechanism of action? Either one, same thing. Online, chime in. There's just one. And look at your options. What do you think? All right, what does it say online? Are they done? Anybody look? Okay. Yeah, it's D. So does Carafate neutralize gastric activity? What does? What neutralizes gastric acidity? Antacids, okay. Is it gastric acid is decreased by inhibiting the histamine? No. That's not what this drug is, okay. This is a pepsin inhibitor. And it's not, the gastric acid is not suppressed by inhibiting that enzyme, triphosphatase, but it does form a viscous substance that forms a protective covering over the ulcer, a Band-Aid. Think Band-Aid. Okay, good job. All righty, now we're going to talk about diarrhea. Diarrhea. Right? All right, and then we're going to jump back. Now this is in chapter 42. Okay, diarrhea is defined as frequent liquid stools. These are the 3 that are on your list that I've listed for you because I love you, as well as their brand names. How good is that? And then also refer you to a table. You need to look at the table because that's where it's going to tell you about these drugs. Okay, that's going to give you some more.
We got slide.
Oh, did I not?
No, like it's not in our PowerPoint.
Yeah,
All the yellow is.
All of the yellow isn't? I would re-download the PowerPoint. Can you what? Yeah, you can type it. I'll give you 2 minutes. You can type. Take a picture. After we're done, if you want me to go back and I can go back and you can take pictures. If you re-download the PowerPoint, you'll see. And then you could just copy and paste into your whatever, maybe. I don't know. Okay. So Lomotil, Imodium, Pepto-Bismol. Okay. All righty. Did you all get your pictures? Okay. All righty. So causes of diarrhea. Again, what's the number one thing you have to find out before you give medications? In GI. What are you treating? What you're treating. Okay. So why do you have diarrhea? So these are the causes. Okay. Some of the foods, bacteria, virus, malabsorption, which happens in inflammatory bowel disease. We'll get to that in just a second. And fecal impaction. A fecal impaction causes diarrhea. How does it cause it? Tell us about it.
It's so impacted that only like the liquid can get like through it around.
Yeah. Did everybody hear that? So this is so common when you're working in SNFs, or if somebody is on opioids, because opioids slow down the bowel, and it gets stuck. And just like you said, the only thing that can go around it is liquid, and that's diarrhea. But they're getting diarrhea because it's stuck. So guess what you have to do? You can either disimpact. If it's down low, you disimpact, exactly. Or you use an enema to go up and around and lubricate and have it come down. And so those are things we're going to talk about. Okay. All right. Stress and anxiety and a bowel tumor. A lot of people will have diarrhea and they think they're doing fine. And, oh, this is, I keep taking Pepto, life's great. And then they finally get painful and they go to the doctor or they come into the ER and we have to tell them they have cancer because we do a CAT scan and here's this big tumor in their gut and their bowel. And it's like, guess what, guys? This is the reason why you get colonoscopies. This is the reason why when something hurts, you get it evaluated. You don't just self-treat, okay? All righty. So let's talk about traveler's diarrhea because there is a question on traveler's diarrhea, okay? You've had that before? It's no bueno, is it? No bueno, okay? It's also known as acute diarrhea. It's horrible, okay? So you can reduce your risk, okay? These are your non-pharmacological ways by bottled water, okay? Most of the time, these pathogens, the locals don't ever get diarrhea from it because their body's used to it. Those pathogens are in it, life's great. We live in the United States and we filter out all that stuff. So your system has never been exposed to those pathogens. They get it and it's like, wow, can't do it, okay? Wash your fruit, cooking. Imodium and Lomotil can slow peristalsis. So it does help it slow down, okay? And sometimes you have to have an antibiotic, okay? So the fluoroquinolone, if it's real bad, okay? Again, that's when you have to get tested, right? You have to do a stool sample, see if you have a bacteria in there that needs an antibiotic. If not, you don't give an antibiotic just because they've been in Mexico, okay? You start with the non-pharmacological and then you move on. So if you're going on vacation, what should you pack in your little bag? Imodium, exactly. Okay. So this is not traveler's diarrhea. This is called inflammatory bowel disease. And there's two kinds we're going to concentrate on. Crohn's and ulcerative colitis. Depending on which area of the bowel that the patient has pain in is where Crohn's and colitis start, okay? Crohn's is an ulceration in the distal end of the small intestine. Which quadrant do you think that would be in? Which abdominal quadrant is going to be the distal end of the small intestine? Right lower quadrant, right where the cecum is, okay? And so they get right lower quadrant and you're thinking appendix, okay? CAT scan shows Crohn's, okay? Ulcerative is erosions in the large intestine. What is the large intestine known as? The colon, okay? And it starts from the rectum and goes up, okay? So if they have abdominal pain that's like, it hurts and then it hurts on my left side and it just feels deep, most of the time it's colitis, okay? So they're treated with anti-inflammatory meds and sometimes they treat them with antibiotics and sometimes they treat them with steroids. Again, steroids reduce inflammation Antibiotics will kill. The best evidence shows that there's usually bacteria in there. Again, that's the most recent, but this is basically where it's at. Okay, severe cases require immunosuppressant drugs such as corticosteroids, and you don't need to know these medications. They're not on the test. Okay, they're just, if these cases are bad, that's what they will do. Sometimes you can perforate. Okay, and ulcerative colitis, ulcer. Remember, if it's not treated, what does the ulcer do? It grows. It gets worse. It goes to the bottom of the bowel or wherever it's at, and it can perforate through. And that's when you have colostomies, and that's where surgeons get involved to save, because now you have bowel contents and that bacteria in the bowel that's always there going into your abdominal cavity. And that is big time no bueno. All right, so here's non-pharmacological measures to do before you start the medications. Sometimes you just get a little bug in there, okay? Clear liquids, anything you can see through. Gatorade, Pedialyte. If you get dehydrated, that's when IV medications solutions come in. It's strictly to treat hydration, okay? And then over on the side, this little picture, this is, you guys went over the BRAT diet this week, right? Yeah. Okay. Avoid dehydration. That's where your clear liquids come in. And try probiotic yogurt. Okay, we talked about in antibiotics, right, how it knocks out all the florals in your body. Probiotic helps put good bacteria back into your gut so that it doesn't allow the bad bacteria to grow. Does that make sense? Okay. All right. Opioids are the best to slow down and treat diarrhea. That makes sense, right? Because isn't an adverse effect of narcotics constipation? Okay, so if you're having diarrhea, wouldn't you want to slow down your bowel? And that's why opioids are the best. Again, you have to address its cause. That's the number one thing you have to do in any of the GI. But opioids are the most effective. The other one, but they do have some abuse, so that's why it's you know, you got to know what you're treating. The other over-the-counter is Bismuth, also known as Pepto-Bismol, okay? And it can help with simple diarrhea, okay? But there are a few things. So the most common opioid antidiarrheal is diphenoxylate with atropine, also known as Lomotil. And there's a question on the test about Lomotil, which is a controlled substance. So this requires a prescription. Loperamide, which is also known as Imodium, does not require a prescription. It is similar to the opioid Lomotil, but your risk for dependence is decreased, and that's the reason why it's over the counter. Anything that has the abuse potential, they restrict it. Okay. The other medications for diarrhea is Bismuth, salicylate, subsalicylate. It's an absorbent. It's used for diarrhea, heartburn, and nausea. Well, that's great. Okay. But again, if it's doing for heartburn, it's just neutralizing the acid. Diarrhea, it's going to kind of help slow it down. This is a problem though, guys, is because this contains aspirin. Okay. So if you're allergic to aspirin, this would be contraindicated, right? You need to be really careful. And it can cause your stools to turn black. It does almost 100% of the time. That's normal. Black stools are not normal, right? If you're talking about GI problems, because that could be a GI bleed, right? But if you're taking Pepto-Bismol, black stools is normal. So it is not to be used in children under the age of 19 because of a very life-threatening syndrome called Reye's syndrome. Okay? So don't give your kids or your sister or your siblings Pepto-Bismol if they're not adults. Okay? I know. It happens all the time. I know. I used to eat aspirin. And if it's children's Pepto, then that would be a different story. But just across the board, again, this is what's in your book, okay? I know. Forget everything you ever know. I know, exactly. I mean, I used to eat aspirin, the chewable aspirin, because it tastes like a little orange. I used to like have a whole freaking bottle of it, you know, and I'm like, little did I know, I'm putting myself into, you know, a metabolic acidosis with that. It coats the GI and it absorbs bacterial toxins. The absorbing of the bacterial toxins, that's how it slows down. Okay. And it treats traveler's diarrhea. There's a key. There's the key. There's the key. You know. Did it cure your traveler's diarrhea, Mark?
Yeah, those black stools, I was getting those.
Yeah. Yeah.
Common side effects.
Exactly. Exactly. There it is, guys. Okay. Wink, wink. Okay. There it is. Talk to Mark. Contraindications, liver disease, okay, narcotic dependence, ulcerative colitis, and glaucoma. It's not going to cure any of those things, okay? And especially with the glaucoma, it's going to make it worse. Check for dehydration. If diarrhea is greater than 48 hours or you get abdominal pain, you need to seek medical treatment, okay? So here's a question. That's a great test question. Somebody comes in with abdominal pain and they're like, oh, I just think I just had diarrhea and I just need a prescription for Lomotil, okay? And you listen to their tummy and they don't have bowel sounds. What would be the best thing to do? Give them Lomotil? What would be a best thing to do? Figure out why they have the abdominal pain, guys. Right? They're going to do some labs. They're going to do an x-ray. Figure out if they have an, you know, need for an enema, right? You got to figure out what you have. Kenna. For what?
Just if they come in, say they had diarrhea and abdominal pain like that.
So if they come into the ER, which we get a lot of abdominal pains, and you know, they've had diarrhea for greater than 48 hours, they are immediately NPO. Because if they do require surgery and we're giving them stuff, you know, we've just screwed up their care. Okay. In terms of, I don't know, anybody work into a clinic, they come in for abdominal pain. Most of the time, you know, they don't eat or drink in case we get this x-ray back or we get this CAT scan back and you got appendicitis or you have whatever, and we got to send you here. So most of the time I would say a yes. It's not on your test question. Okay. But in terms of for you as a nurse, if you're evaluating somebody with abdominal pain, don't give them water, okay? Just keep them NPO till you figure out why the heck they have it, okay? All right, good question. All right, so let's go into constipation. This is the opposite of diarrhea, okay? This is also in chapter 42. So constipation is defined as an accumulation of hard fecal matter in the large intestine. Large intestine is also known as colon, okay? This is not small intestine, okay? This is, constipation is in the large intestine. If you have something going wrong in your small bowel, it's called a small bowel, starts with an O, say it loud, obstruction, small bowel obstruction, yeah. And that goes into your intussusception. Those are the other things that you covered this week, okay? And then these are the ones, and I'm sorry, I can go back, take a picture. For those of you who are online, you probably don't see this. I can go back. When we're done, I'll go back through. Is that helpful? I don't know. Help me online. What? Okay. All right. Mark says he's got it covered. He's going to send it to everybody. Okay. Is that good? All right. Okay. I was trying to help you out. It really was. Okay. So these are the kinds of medications that you treat for constipation. So these are also known as what? Starts with an L. Laxatives. Okay. So that's your classification, laxatives. All right. And in the big broad classification of laxatives, they have 4 different kinds. One is osmotic. The other one is bulk. The other one's kind of an absorbent. And the other one's like an emollient. Okay. The most common enema that we give in the ER, we call it the brown cow. The brown cow, because it has whole milk. Okay, whole milk has a lot of fat, right? So it has a lot of grease with that whole milk, and it also has oh my goodness, it's in a big gallon. It's brown. It's molasses. Molasses. We mix whole milk and molasses in an enema bag. We warm it up because it's cold, right? And that would like, your poor patient would like, we go, "Wah!" Okay, we warm it up. So the sugar that's in the molasses breaks down stool. The oil that's in the vitamin D, the milk, makes it lubricant. We put it in, we give a little bit so that it starts working on the bowel. We give it a little bit more because remember, you're only going in 3 or 4 inches, right? At the most. And we let it set a little bit, then we get it back up, and then we'll increase we'll deliver the rest of that. And then it's like, hold your butt cheeks together as long as you can. And then they get rid of, you wouldn't believe, because it's lubricated and it's broken down and away it goes. Okay, that's not on here, but that's real life. You will give brown cows. Okay, all right, here we go. So the causes of constipation: insufficient water intake. That's the reason why older people get constipation. They don't drink enough water. Okay, poor dietary habits. This is the number one cause. There are questions on the exam about the number one cause that people get constipation. We don't eat right, guys. We don't eat enough fruits, vegetables. We don't eat it. We eat stuff that's full of sugar, full of carbs. It slows down in the gut and it gets stuck. Okay. Fecal impaction, bowel obstruction, the list goes on. Lack of exercise. Okay. So if you, they're great test questions. If you have a kid that comes in for evaluation of abdominal pain because he's been constipated, and the physician decides, nope, we're not going to give a laxative, what would you encourage as a nurse? What would you teach the parents to do? Okay, increase your activity, increase that. What else? From this list, what else would you do? Fiber. Okay, increase fiber, fruits and vegetables. What else? Oatmeal. Decrease the sugar. What else? It's the same reason that older people get constipation. Is anybody chiming in online? Yo, water. Water. Not soda pop, water. Okay? All right.
Corbie says to point the camera at the screen. Oh, yeah. Oh, my bad. Yeah. We good. That was nice.
Okay. We're okay? Okay. Sorry. So the non-pharmacological measures over on this other side: high fiber diet, water, exercise, reduce the sugar, and routine bowel habits. Normal can be 1 to 3 times daily or 3 times a week. Every person is different. That's important to know. Okay. So this is the difference. The difference is, so when we talk about saline, I'll wait for you. Saline is an osmotic, okay? And so this laxative causes water to be retained in the fecal mass, okay? When you have more water, is that going to help move things through? Yeah. And it produces a bowel movement within 1 to 6 hours. There is an FDA warning because remember, osmotics have huge fluid shifts. And so they're shifting the fluid into the bowel, and it can cause severe dehydration and electrolyte depletion. Okay. One of those is called lactulose. But lactulose works amazing, and here's the caveat. That's the reason why it's highlighted. That's the reason why it's a different color for those that have hepatic encephalopathy. When you have hepatic encephalopathy, you're not getting rid of your ammonia, and it builds up in the blood and in the system and in the stool. Lactulose helps get rid of ammonia in hepatic encephalopathy. So when someone comes into the ER that's confused, that has ascites, that's not working well, that we know has hepatic encephalopathy, this is one of the drugs that is ordered, is to give them an enema. It's the last drug I give. Lactulose, it's what you drink. It's the last drug I give because why? It produces a bowel movement how fast? 1 to 6 hours. So I want them down at the floor. Okay. So understand when you administer these osmotics, they happen quickly. Magnesium citrate is another one. Okay. And that's used for bowel preps, for colonoscopies. It's just this little, 16 ounces, but holy smokes, you think you're flying to Mars when you're sitting on the toilet, right? Okay. All righty. Okay. So important about lactulose, important about saline osmotics. So there's another form of a laxative. It's called a stimulant. Okay. It promotes peristalsis. That's that mechanical pushing by irritating the bowel mucosa. Okay. It irritates it usually with like a sodium, and the bowel goes, wait a minute, what's going on here? Okay. We don't like this. We're going to push it through. It doesn't know the difference, whether it's a neurotoxin or whatever. It just pushes it through. And it irritates it, and the bowel's like, not having it. We're pushing it through, okay? And it's rapid acting, and it's more likely to cause diarrhea and cramping. You will have this because, again, it's peristalsis. It's squeezing. It wants it out of there, okay? It should only be used occasionally because you can become dependent, and you can lose the peristalsis that your bowel naturally does. And I saw that in a patient, and he ended up with a colostomy. He came in just thinking he had constipation. We were just going to give him an enema. Remember, we talked about make sure, what you're treating. So we did a CAT scan. We did blood work, and it was no bueno. His colon was completely gone from the ability to push fecal matter through because of his years of using Dulcolax. And the surgeon came in, and he said, you get to have a colostomy, and we're going to surgery now. And and can you imagine that you're getting that diagnosis when you thought you're just going to get an enema? Okay, so there's two kinds. One of them is called Dulcolax. The other one is called Senna or Senokot. You'll see these a lot of times in people that are in SNFs, right? This is you see it all the time. Again, it's a stimulant. It irritates the bowel mucosa, okay? All right, bulk forming. So this is a little different. It's different than the osmotic, and it's different than the stimulants. This absorbs water. One of the main purposes of the large intestine, the colon, is to suck water out. So it puts it back into the body. So what this laxative does is it keeps the water in, okay? So it keeps it going through and lubricating, and it's good. It doesn't make it hard. That's what constipation is. Keeps it soft, okay? It absorbs water, and it adds to the mass of the fecal mass. It's used for prevention and treatment of chronic constipation, okay? It has a very slow onset. Okay, there's your differences, okay? So if you were wanting something rapid, would you use a bulk forming like Metamucil? No. Oh, I think those are really some good test questions. Which one would the nurse use? Yes.
So just like with the osmotic and the bulk forming are both adding water to the
right.
mass.
Other than
One's faster, one's slower.
right, and it adds water. It keeps the water. This Metamucil, it keeps the water as it goes through the small intestine and keeps it when it's in the large intestine. Whereas the saline, the osmotic, shifts fluid from the body into the colon. Does that make sense? Yeah, that's your fluid shift. Yes.
So would Miralax be more of a bulk forming or an osmotic? There's a picture of it on the osmotic. Just to clarify.
Yeah, it's a little bit of both, but it's more bulk forming. And I apologize if it's on the osmotic. And again, some of these will have different compounds with it, but Miralax is the polyethylene glycol is the bulk forming. So, and then the psyllium mucoid, that's also known as Metamucil. Okay. And the off brands are the same thing. Okay. And it's not used when a rapid and complete bowel evacuation is necessary. So if you're doing a colonoscopy prep, you're not going to have Metamucil. You're not going to have any kind of bulk. It's going to be rapid. It's going to be quick. It's going to be the Dopalax. It's going to be the magnesium citrate. It's going to be the osmotics. Okay. The stimulant and the osmotics, if you need to get everything out and you need it, within a day. Okay. One of the things, this is great, and this is what I tell patients that come in and they have a fracture, okay, and we're sending them home. They don't have to have an operation to fix their fractured ankle, but it's fractured, and we're sending them home with narcotics, okay? They're going to be taking narcotics for a while, okay, a couple of days, maybe a week. I always say, when you take your narcotic medication, take it with a glass of Metamucil, and then chase it with another glass. Because if this is absorbing water, part of what you take Metamucil with is a large glass of water, and then you follow it with a large glass of water, because it takes a lot of water to keep that, okay? And the reason why I tell them this is because I learned this with my daughter. She had a fracture dislocation of her right ankle and ended up having 4 surgeries so that she could walk over the course of 1.5 years. She couldn't walk on grass. It was that unstable. Anyway, so obviously 4 ankle surgeries, they used the same scar, which was helpful, but 4 ankle surgeries, and she's on narcotics for, a couple of weeks. Constipation's a huge thing, right? So we started giving her a glass of Metamucil with her pain pill. Guess what? She was fine. No constipation. So again, it just helps bulk. You chase it with another glass of water. Life's good. Life's good. Okay? All right. It's slow. Then you have stool softeners. Now, stool softeners are different than a bulk. Okay? This causes more water and fat to be absorbed into the stools as opposed to going away. And it's used to prevent constipation. So this is not a bowel prep. This is not, when you are constipated, this is when you want to prevent constipation. That's important to know. And especially in patients who have gone surgery or they've had a myocardial infarction, they will put them, an MI, a heart attack, they will put them on Docusate, Colace. It is the number one thing because it prevents it so that they don't strain when they're defecating. Why would that be important after surgery or after a heart attack? Okay, someone said muscles. Don't we use the muscles? The incision, great point. Mark, what was yours? Increased pressure. Increase on the heart, right? Yeah, you're straining. How many people have heart attacks sitting on toilets and they bagel down, right? And they pass out, right? It happens. And especially in abdominal surgery. Those of you who work postpartum, don't you have Docusate on many of the postpartum? Yeah. Not all of them, but a lot of them, especially like if hysterectomies. Of course, hysterectomies now kind of go home, but they don't want you straining because they do it robotically. If they remove the cervix, they have some sutures in there that are absorbable, but they're long time absorbable. So like 4 weeks it takes to absorb. They don't want you straining, having a bowel movement. So they will send you home on Docusate, on Colace twice a day so that there's no way that you strain for all of those reasons that you stated, the incision, okay, the muscles, the bearing down, all of that, the pressure, all of that. Okay, good job. There are questions about Colace and why you use it or what would be the number one thing to use it for. Okay, we just talked about it. Miscellaneous. This is where it acts differently than the other things that we've talked about. Again, stool softeners prevent constipation. Okay, miscellaneous, mineral oil. Why would mineral oil be something you would take? It lubricates, right? It's not digestible. It goes right through the stomach. It goes right through the small intestine, and it stays in the large intestine. It lubricates and goes down. Glycerin suppositories cause to fix constipation, right? You do that in little babies all the time, right? In pediatrics, why? Glycerin is an oil. Okay, it helps soften, helps lubricate, has a little bit of a stimulant, and out comes the little balls of poop. Or in the ER, usually it's little balls of candy, little balls of gum, those things. Yeah, it's great. Okay, here we are, last little things. And then we get to go, and I will answer any kinds of questions. Okay, so patient complains of constipation, requires a laxative. In providing teaching for this patient, the nurse reviews the common causes of constipation, which are good job. Yeah, number one cause. Again, these are questions that are specifically written. They come right out of your book. Okay. Poor dietary habits. Number one cause of constipation. Okay. A patient complains of constipation and requires a laxative. In providing teaching for this patient, the nurse reviews the common causes of constipation, which include, that's the same one. Okay, so any questions before we talk about our learning activity? Okay, so in your book on page 632 is a critical thinking case study. I don't want you to answer all the questions, just 6. Give me 1 or 2 questions. You've already answered these. We've gone over them. Just put it in a document, either, a Word document, because I'm asking for 2 to 3 sentences, as opposed to it's bad or because it's good, because you said so. Okay, give me a legitimate answer. All right. And just upload it sometime before midnight. Okay. We have stopped 35 minutes before class is specifically supposed to be over. So if you want to do it here, you totally can. If you want to say, no, I'm out of here, just get it uploaded before midnight. It is worth 100 points. Yeah. Okay. Questions? Somebody wants to chime in?
I do.
Okay. Any questions online while we're here? If you want to borrow this book, you can borrow this book. If you have a half hour, it'll be done.
Hey guys. I got a night shift to do. I know. I don't really work on Facebook because we go to primaries on Fridays.
Right.
Switch me around. Yes, I would like to borrow this book.
Okay.
Gracias.
Hey, you're welcome. Hopefully this was helpful.